We'll just start in, give me 10 minutes, sir, because people are just coming from lunch.
Sure.
Dr. S. Gupta has obliged, he's sitting right in front of me. So,
Yes, Dr. Gupta, don't mind. Actually, I already asked my family members. This is Sunday, that's why I asked them to come just after few minutes.
बेटा एक आदमी जाए सबको बुला के लाओ, बड़ा लेजी हो जाता है. निकिता, सबसे कहो अंदर आए जल्दी से. हैं?
एसी डिपार्टमेंट.
क्या?
एसी डिपार्टमेंट से.
बिल्कुल गर्म लग रहा है मुझे तो पता.
सर वो बात आप बिल्कुल ठीक है, पर पीछे से हमने एसी को ना बिल्कुल हीटिंग को बिल्कुल बंद कर रखा है.
वो तो आप एसी चला दो ना.
सर एक सेंट्रलाइज है ना, एक टाइम पे एक ही चलता है यहाँ पे. इस समय पूरी बिल्डिंग में हीटिंग चल रही है.
तो ब्लोअर तो चलाओ.
ब्लोअर तो चल रहा है ऑलरेडी. ब्लोअर हमने चला रखा है, हीटिंग बंद.
ठंडा करने का क्या तरीका है?
ठंडा तो इस समय नहीं, इस समय नॉर्मल हो सकता है, पर ब्लोअर
नॉर्मल तो करो.
नॉर्मल चल रहा है सर ऑलरेडी. तो कुछ टाइम से थोड़ा सा गेट खुला रखिए, हो जाएगा.
अभी हम जा रहे हैं. हाँ 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 हाँ, कल दिखा दे. कल 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 3 बजे कल. I think we can start, na? Okay, so we move on to the post-lunch session. We are running late by 15 minutes or 40, rather than 25 minutes. So we finished mitral valve symposium. We finished lipids, diabetes symposium, heart failure. So now after lunch we have a coronary artery disease symposia, which will be having multiple talks from Dr. S.K. Gupta, acute coronary syndrome diagnosis management, our senior colleague, Dr. M.K. Das, very senior cardiologist from Kolkata, case-based learning in coronary artery disease. Then we'll have Dr. Anil Dhan, occlusion MI, OMI, a new paradigm. Then we'll have Samir Kubba talking of cangrelol, a new paradigm in antiplatelets. Siddhant Rehan will talk about if bypass my only option. And Dr. Deepak Jain from Germany will speak about protected PCI with Impella. So may I request Dr. S.N. Pathak and Dr. Vimal Mehta to please come on the stage to join the panel as a panelist and chairperson. So Dr. Das, Dr. M.K. Das, इनको unmute करिए. Have you started the live, Facebook live?
Yeah.
Okay. So I have to introduce you again regarding Dr. M.K. Das' seniority, his role in the CSI, Cardiology Society of India, and role in the global map, especially in heart failure. He's the president of Asian Heart Federation, past president of CSI, giving talks all over the world now, and trying to give a big boost to the academics of India globally by his presence. He's a fantastic speaker also, and this time he's going to talk about case-based learning in coronary artery disease. He will show 1 or 2 cases for us to learn from the cases, because why medical practice is known as practice. So people ask why you're practicing, you're still practicing. So the reason is that we learn from every patient, and that is why it is known as private practice or government practice. I don't know who devised this word. Seeing the patient is a practice. So that's why case-based learning is important. Dr. Das, please go ahead.
Yes. Uh, uh,
Dr.
Good
Pathak is
afternoon
our colleague in
once again,
Apollo. Yes, sir.
and and I am thankful to Dr. Vivek Gupta for giving me the opportunity. He's a fantastic guy, and we'll be see his own what is called performance in the evening. Uh, but thank you, Dr. Vivek Gupta, for your beautiful words. I'm not going to discuss many cases, just one case which was a quite challenging one. It's a multi-vessel coronary artery disease. I presented this particular case in one of the NICs also, and it was having a anomalous RCA origin, and that was intervened. That's what I'm going to show you, and how it was done, and what are the challenges we had to face. This is a very common slide. These are few of the indications of using the Guidezilla or guideliner catheter, which is an extension catheter in addition to the the standard guide catheters for doing the angioplasty. Now, one of the indication is the total coronary occlusion. Then this very tortuous coronary arteries, then this screw type of RCA origin, and very complex cases where you may be failing to negotiate the various hardwares, then possibly the Godzilla or guideliner catheters may be of help. Now, my case was a 55-year male, and he came with chest pain and comorbidity was hypertension. These were his vitals, and he had raised tropi. ECG showed inferior and anterior wall ischemia. Echo did not show any regional wall motion abnormality, and the ejection fraction was normal. There was a grade 1 diastolic dysfunction and mild MR and TR, and CAG rebuilt TVD at LAD, LCX, and RCA, and we diagnosed it as ACS, and we planned for total revascularization by doing PTCA to all the three vessels. So these were the steps planned and performed, procedure done by RFA with 7 French sheet, and we used 250 ml of dye and used also 8,500 international units of heparin. And we negotiated the 6 French EBU, and we did the PTCA stenting to LCX and LAD. I'll show you some of the clips, but I'll jump over the clicks to show the RCX in a little bit detail. And PTCA at RCX was done through EBU guide catheter, where whisper were stent, where was sent to distal RCS, sequential dilatations with 1.5 by 5 millimeter, a balloon was done, and mother and child technique used with the 4 French Godzilla telescope through the EBU, and supraflex card stent was deployed. So these are some of the slides, some of the clicks where it is showing the left coronary arterial system, and both the LAD and LCX after this origin is showing the stenotic lesions. And you can see when the dye is being given in the LCA, we could visualize the RCA as well. So naturally, we knew that we are going to have a problem because of the thing that we found the RCA was also abnormal, and this intervention will require a lot of manipulation. So RCA from left coronary cusp was seen, and we put the guide wire across the different vessels on the left system. That first LCX, then we pre-dilated with balloons at different levels and put the stents over there. Then we did the LED stent also pre-dilatations with balloons at different sites, and they put the stent in the LED as well, and thus the left side was taken care of. And then we switched over to the right coronary artery, and here you can see the right coronary artery originating from the LED has been guide wired, and while dilating the different stenotic lesions at different levels, we were finding it difficult. That's why we thought that let us put a Guidezilla extension catheter through the ABU, and then it became easy to some extent by putting the balloon across the different lesions, and we dilated it, and that's how the Guidezilla is being shown. It has been put through the ABU, and thereafter, after the pre-dilatation, stent was negotiated across the EBU and the extension catheter, that is Guidezilla catheter, and we just localized the lesions, and we also dilated or inflated the stent, and then ultimately this was the result on the right coronary arterial system. This was the result. So ultimately, we could achieve the three vessel revascularization. So the carry home message from this particular case is that never to be dispirited when the anatomy is difficult. Some solution must be there, and even if it is an anomalous origin of RCA from left coronary cusp, and which is not very unusual. Many people are encountering it, and they are doing the procedures. In complex coronary artery disease like anomalous origin of the artery, CTO, highly calcified lesions, coronary artery with steep angulation or tortuosity, this mother and child technique is quite salutary and safe in successful deployment of stents. Hardware like Guidezilla or Guideliner may be quite handy. It is safe to use, and the results could be very salutary, as I already told. The only precaution to be adopted during the procedure is that one must follow the guiding catheter as well as the Guideliner, because if you are actually keeping your focus away from them also while putting the stents or putting the balloons, then there might be slippage, and there is a possibility of dissection of the proximal artery inadvertently or due to diminished alertness. And that might create a lot of problems, especially in these type of cases. And that's why use of appropriate hardware may enable us to complete a complex procedure like three vessel disease, complex three vessel disease with calcifications or with anomalous origin of the coronary arteries. So that was my case. Many thanks for giving me the opportunity.
Yes, there is no doubt every case is learning, and the choice of hardware very important. I always tell all my junior colleagues the safety first, success later. But we want success and safety together. But sometimes to achieve success, you land up with problem because you choose a different hardware. You go beyond whatever is required. And maybe we can have one comment from Dr. Vimal and Dr. S.K. Gupta, another comment
Yeah,
about the case.
very nice case, sir. Actually, I'm from a government
Mic,
setup, and
mic.
recently,
Mic,
I mean,
mic.
since last 6 months, earlier it was not available. It is available free of cost, and as you so nicely showed, it has made our life easier. especially as you nicely showed, anomalous region or even tortuous left circumflex kind of situation, or even very tortuous arteries, and where calcification is there, which is not allowing your stent to go, then you can take the support of, and it makes, as you so nicely showed, it makes your life easier and the procedure much less complicated, rather than pushing and fiddling over there. You can cleanly, quickly finish the procedure and safely also. Thank you, sir, for a wonderful case.
Thank you very much for the comment. Yeah, Dr. Das, could want to say something?
No, thanks for his beautiful comment, and also thanks to you for giving me the opportunity.
Are you staying back for a while? Staying back?
I'll be there sometime. My computer will remain open.
Okay, so I just want to tell you that our chief guest is Bhagwan Krishna. Can you focus on the Bhagwan Krishna? Can you focus this? So I always feel that the chief guest is always God, and the rest are all guests of honors, which will be having a valedictory function in the evening. थोड़ा नीचे करिए कैमरा, थोड़ा सा नीचे करिए. Yes, yes. थोड़ा इधर. Can you just shift to the camera? That's. हाँ.
Yeah. I am writing something on Krishna. Apart from my clinical works, this is one of my passions.
And you know that Dr. S. Gupta name is Sri Krishna.
Namaskar.
He's sitting there. So भगवान के अलावा तो कुछ हो ही नहीं सकता. Whenever you are problem, मैं शाम को वैलिडिटी फंक्शन में एक आपको स्टोरी सुनाऊंगा लंदन में कि how I caught the flight. 15 minutes Heathrow, 15 मिनट पहले पहुंचा, और nothing was possible, and Air India flight ने हमको अंदर ले लिया when the flight was in time. So I'll share this story during the valedictory function.
Just a little comment, because I'm getting the chance. That's why I'm telling. There are actually in Mahabharata there are 4 Krishnas. One is Vasdev himself. Second is the Madhav or Krishna. Third was Arjun's name was also Krishna, and fourth was Krishna, that is Draupadi. And all of them actually worked together in cohesion to do the righteous thing. Just for your information, I'm giving this particular.
एक आपने ये बात शुरू की महाभारत की, तो मैं एक छोटा सा एनेक्डोट सुनाता हूँ. सबको पता भी है और नहीं भी पता है. जब कर्ण और अर्जुन का युद्ध चल रहा है और भगवान कृष्ण सारथी हैं, तो क्या हो रहा था कि कर्ण was of course considered to be a little more powerful than अर्जुन. तो जब कर्ण तीर चला रहा था, तो अर्जुन का रथ 1 मीटर पीछे जा रहा था, और जब अर्जुन का तीर चल रहा था तो कर्ण का रथ 3 मीटर पीछे जा रहा था. देखिए 3 मीटर, यानी कि अर्जुन का रथ कम पीछे जा रहा था, लेकिन कर्ण का ज़्यादा पीछे जा रहा था. तो उसके बावजूद एक कृष्ण भगवान अर्जुन का जब तीर चलता था उस पर वाह वाह नहीं करते थे, जब कर्ण का चलता था तो उसको वाह वाह करते थे. तो अर्जुन बोले कि देखिए मेरा चला रहा हूँ, उसका 1 मीटर जा रहा है पीछे, और वो चला रहा है तो मेरा 3 मीटर पीछे जा रहा है, 1 मीटर मेरा पीछे जा रहा है, मेरा 3 मीटर, तब भी आप उसकी तारीफ कर रहे हैं. तो भगवान कृष्ण बोले तुमको पता है तुम्हारे रथ पर एक तो मैं बैठा हूँ और दूसरा ध्वज में हनुमान जी बैठे हैं, उसके बावजूद भी कर्ण के तीर से आपका रथ 1 मीटर भी जा रहा है, बहुत बड़ी बात है. ही इज मोर पावरफुल देन यू, वी हैव टू बी कॉशियस. इसीलिए उन्होंने गलत तरीके से उसको मरवाया. ही न्यू कि अदरवाइज इसको मारना मुश्किल है. तो भगवान कृष्ण की महिमा है, अलग अलग तरीके से है और सब लोग देखते हैं. थैंक यू वेरी मच डॉक्टर दास, एंड वी हैव टू मूव फॉरवर्ड बिकॉज
this also tells us when you have a mentor, continuous mentor support with you, then it makes you more your results are much more flourishing and are there. If you
many times
mentor support is there, this shows. So because Krishna ji
was mentor of Arjun.
Very nice story, sir. Very nice.
नहीं तो उसमें कई एनेक्डोट्स हैं, वो शाम को एक अलग विषय बन सकता है अगर इस पर तो बहुत चर्चा की जाए लंबी, क्योंकि भगवान कृष्ण के क्या रूप हैं उन्होंने और राम के क्या रूप हैं. राम ने तो कभी अपने भगवान बनाया नहीं कि मैं भगवान हूँ, वो तो बाद में पता लगा लोगों को, अरे तो भगवान है. और कृष्ण ने हमेशा बताया कि मैं भगवान हूँ. ये फ़र्क है दोनों में. और कृष्ण ने छला भी है लोगों को. भगवान राम ने पूरा मर्यादा पुरुषोत्तम के साथ, उन्होंने कभी भी एक्सेप्ट बाली वाला युद्ध जो था जिसमें उन्होंने पीछे से वार किया, अदरवाइज राम ने तो पूरा, इसीलिए उनको पुरुषोत्तम मार राम कहते हैं. और कृष्ण ने अलग तरीके से अपने किया. लेकिन हम लोग जब एंजियोप्लास्टी करते हैं, भगवान ये डॉक्टर एस गुप्ता बैठे हैं, तो कई बार स्टैंड नहीं जाता है तो हनुमान जी को याद करता हूँ, चला जाता है. Okay, we move on to the next session, and Nagendra is there. He will be talking about, but Dr. S.K. Gupta, may I invite him for his talk on acute coronary syndrome, our senior colleague in Polo Hospital, Delhi, and a lot of experience, and he will be talking about the basics of acute coronary syndrome, which everybody should know. I want to tell you, those people, not many heads are there, but this is Facebook Live, YouTube Live. So it will be seen multiple times by many people because we have a lot of followers on Facebook, about 15,000, YouTube about 10,000. It will also go to Insta, and we have a lot of friends where it can be seen later on. So this education will be having a long-term impact, not just people sitting here. It will be having a long-term. So your talk will be circulated all over the world. Thank you.
Thank you, Dr. Vivek. May I have the first slide, please? Yeah. I'm supposed to talk about acute coronary syndrome. In this 15-20 minutes time, I thought I will not go into very hi-fi things. I will give you basic idea about acute coronary syndrome and how we should treat them. First, the definition of acute coronary syndrome. Acute coronary syndrome is a spectrum which includes unstable angina, non-ST and ST elevation MI. There are classical symptoms and non-classical symptoms of ACS, and for interpretation which type of ACS this is, we need ECG and enzyme studies. Definition spectrum, as I said before, it's a spectrum ranging from unstable angina to ST elevation MI. The classical symptoms of chest is chest pain, which may be like burning or pressure over the chest or tightness over the chest. And the pain may not be only in the chest, it may radiate to jaw, neck or back or hands, which I will be showing in the next few slides, beautiful pictures. Then it may be associated with other symptoms like nausea, vomiting, breathlessness and sweating. These are the classical symptoms of angina, and this is one of the very good slides. It shows how pain can happen at various places, and it can be so confusing many times so that you may have difficulty in diagnosing. Classically, it happens in the center of the chest or left side of the chest. Then it can radiate to the neck, to the jaws, sometimes to the left arm, and rarely, not really rarely, uncommonly to the right hand of the also, but inner side of the, not the outer side. If the pain is happening out on the outer side of the hand, it's likely to be cervical. If it is happening on the medial side, inner side of the hand, it's likely to be anginal pain. Then another important thing is that sometimes the pain may not be in the chest, it may be epigastric pain. And many times we confuse that this may be abdominal pain or gastric pain, and there is a lot of confusion. So here there is a small tip that if the pain is happening above the navel, then it's like it may be because of the heart. But if it is happening below the navel, नाभि के नीचे और नाभि के ऊपर, सिंपल भाषा में अगर नाभि के ऊपर पेन है तो इट कैन बी हार्ट पेन, नॉट नेसेसरली हार्ट पेन. But अगर नाभि के नीचे है तो chances are that it will not be heart pain. Then sometimes pain can happen only in the arm, inner side of the arm, right or left, or sometimes on the back, in the interscapular region, what we classically say. That all time also we should suspect that the pain can be heart pain. Then there can be some atypical symptoms like abdominal pain, we said. Pain may be like burning in the chest. It may not be really pain, but there may be खट्टी डकारें आ रही हैं, जलन हो रही है सीने में. That can kind of pain. Cold, clammy skin, lightheadedness, dizziness, fainting, fatigue. Simply person feels fatigue. He may not have pain, nothing may be there, but he feels exhausted and fatigue. One should suspect if circumstances are like heart disease and feeling of restlessness and apprehension. If these atypical symptoms are there, these are common in people who have got diabetes. They may not have classical chest pain, they may have all these atypical symptoms. Or women, symptoms may be very confusing. Renal failure, elderly people. In these group of people, atypical symptoms are more common. So we should keep that thing in mind that if atypical symptoms are there and other, circumstances, evidences are in favor of heart disease, one should strongly think about coronary artery disease and should not, kind of neglect coronary artery disease. Now, how to differentiate these three ST elevation MI, non-ST elevation MI, unstable angina? Very simple. We have to take a ECG and do a blood test, tropi test. If ECG shows ST segment elevation, tropi increased, that means ST elevation MI. If ECG shows T wave inversion or ST depression with enzyme elevation, non-ST elevation MI, or if these findings are not there, tropi, enzyme studies are normal, then it is unstable angina. So this is a good algorithm when patient lands to emergency or to your clinic. What we do, we simply take a ECG, and if ECG is, by the way, normal, it doesn't show any classical changes, then in that situation we should repeat the ECG about in 15 minutes to 30 minutes time again, and see the serial ECG should be seen whether the changes are appearing later on. At the same time, we should do cardiac enzyme and repeat them at the interval of about 3 hours. Sometimes first, because usually tropi increases after 3 hours, and the patient suppose comes within 3 hours, the enzyme level may be normal. So you should repeat at the interval of 3 hours and then see whether the next set of findings, ECG and enzyme showing changes or not. Then sometimes a transthoracic echo may be very helpful. See, ECG may be normal, tropi may not be increased, but if you put a probe over the chest and see the echo, it may show regional wall motion abnormality, and you will clinch the diagnosis and treat the patient effectively. If there is a ST segment elevation or new onset LBB, or patient is already on pacemaker, then we have to be careful in diagnosing, because LBB or pacemaker rhythm may mask the findings of acute MI. And of course, in this situation, if there are changes in the ECG, tropi will be done, that will indicate infarction. If there is no ST elevation, but there is ST depression or T wave inversion, then do tropi. If tropi is positive, it is non-ST segment elevation, ST segment MI. And if tropi is negative, this is unstable angina. So simple way to diagnose and simple way to proceed further. The pain, of course, as classically, how we say that this is unstable angina, if patient was having pain before, then now the pain becomes more severe, more frequent, occurs at the rest, or it is of new onset, then we should suspect that this may be acute coronary syndrome. Troponin, as I said before, is a very important test, but it takes about 3 hours to become positive. Sometimes we can do CKMB. CKMB is usually more helpful when this happens after some procedure like PCI or CABG. If you do CKMB, then that will be more informative. And or otherwise, if tropi facility at some places in your clinic or in some hospital, primary healthcare center, etc., are not available, then CKMB is another important test and which helps us in diagnosing acute coronary syndrome. This is what TROP-I curve shows. It rises in about 3 hours time. It peaks at about 48 hours, and by the end of the week, it becomes normal. Not only that, the level of the TROP-I is very important. If TROP-I levels are very high, it indicates that there is a more damage to the muscle. It simply says that there is a more damage to the muscle and infarction will be more massive. Now, the infarction nowadays has been divided into many categories like type 1, 2, 3, 4A, 4B, and 5. One is spontaneous, जो classical heart attack होता है, type 1 is that. Type 2 is secondary to the ischemic imbalance. That means that there is a lesion, but there is some stress or some stress on the body which has precipitated the infarction. Type 3 is resulting, the infarction resulting in death, but enzymes are not elevated. Type 4 and A and B are following PCI or following by stent thrombosis. And type 5 is MI following bypass surgery. So these are, from theoretical point of view, these are categorized into different categories. But so far as the practical management is concerned, it doesn't make too much of difference. This is what we said. Type 1 is that there is a atheroma in the artery which suddenly ruptures and leads to occlusion of the artery and infarction. Type 2 is, there is a lesion of course, but it is not responsible directly because of the occlusion of the artery, but there is a stress on the body. Somebody has done exercise. We many times hear that so-and-so playing football suddenly collapsed and died. This is what, although he did not have significant coronary artery, but because of the stress, he had, developed infarction, arrhythmia, and death. ECG changes. This is what, kind of a take-home message. This is what happens in acute MI. There is a development of Q wave, there is elevation of the ST segment, and there is inversion of the T wave. The timeline of these findings depends on how much is the muscle damage. Once the muscle is normal, there will not be any change. But in the initial stage of the infarction, when there is only endomyocardial is damaged, then there will be tall T waves. And once there is a through and through infarct, there will be Q wave formation, ST segment elevation, and later on T wave inversion. This is what happens, diagrammatically it is shown very nicely. Normal ECG. And then in minutes after ischemia, there is a tall T wave. In minutes to hours, there is ST segment elevation and a reduction in the height of the R wave. And then later on, there is a Q wave formation, ST segment elevation. And in days' time, the ST segment then starts coming down, Q wave formation, T wave inversion. And in months' time, weeks to months' time, the Q wave becomes prominent. There is a R wave becoming reappearing, and the T waves become upright. These are the classical changes in acute infarction from hours to days, to months. This is another, common information. What is the relation? As we know, there are 3 arteries in the heart: LAD, circumflex artery, right coronary artery. In which infarction, which artery is involved? It's a, for like in MBBS days, we used to be, taught about all these things. And for a common physician or general physician, it may be a good information. Left anterior descending artery, when occluded, it leads to anterior MI. And the changes will be in anterior chest leads, anterior chest leads, and the reciprocal changes will be in the inferior leads. If there is an inferior valve MI, the involvement is right coronary artery. Changes in the inferior leads and reciprocal changes in lateral leads. If there is a lateral infarction, then circumflex artery is involved, it's blocked, and changes will be there in lateral leads, and reciprocal changes will be in V1. Similarly, if there is a posterior valve MI, then it's the artery blocked will be the PDA, and there may not be any indicative changes, but reciprocal changes will appear in V1 and V2. To show you some of the ECGs, we can see here anterior septal MI lead changes in the V1, V2, V3, V4. Lateral MI changes in the lateral leads. Inferior MI changes in the inferior leads. This is when there is a occlusion of the proximal LAD, the changes will be in lead 1, AVL and chest leads, and reciprocal changes in inferior leads. Classical acute antival MI. This is what's seen in the inferior valve MI. You can see changes in the inferior leads ST segment elevation and reciprocal changes in anterior chest leads. This is what called a tombstone giant R wave pattern. Anterolateral MI, you can see the massive ST segment, frightening ST segment elevation in chest leads and reciprocal changes in the. This is the kind of ECG, if somebody comes to the hospital or to the clinic, we have to act very fast. These are the people who can have suddenly arrhythmias and die on the spot. Now this is another important question. In the presence of LBB, how to diagnose infarction? Our patient is on pacemaker, because pacemaker leads to LBB type of pattern. Then how to diagnose infarction? Here, very simple. You see ST segment depression in leads where R wave is positive, or you can say lead 1 or V5, V6. If there is unusual, more than 3 millimeter ST depression, you see like this on the right side panel, then you should always suspect that something is going wrong and it may be MI. Or in a negative lead, that means lead V1, if there is an unusual ST segment J point elevation, please suspect that this may be acute MI. There are some criteria given by Garbosa in the presence, how to diagnose infarction in the presence of LBB. He has said almost same thing, but one thing more he said, that in lead L1, if there is a ST segment elevation as shown here with a red arrow, there is a little ST segment elevation. Normally this should be at the baseline. It should be here, but here the ST segment has gone up. Please suspect that there may be something going wrong here. Or as seen in the other marker. कैसे or see here, in a lead V1, V2, V3, if there is ST segment depression like this, J point depression, suspect acute MI. Or as we said before, or if there is unusual ST segment elevation, please suspect acute MI in presence of LBB. And this is what, you can see very classical LBP pattern. And see the ST segment depression. ST segment, unusual ST segment depression. Please suspect acute MI in presence of LBB. So, non-ST segment elevation MI, there will be ST depression or T wave inversion And if you do the enzymes will be elevated. This will be known as the segment elevation of I. If the unstable angina, there will be non-specific STT changes and enzymes will be normal. This is one of the take-home message slide. Here, how to risk stratify. A patient comes to you with unstable angina or acute non-ST segment elevation MI. Then how to, risk stratify them. What is the risk he is carrying? So there are 7 criteria. We take the age of the patient, 65 years or more. Risk factors, 3 risk factors like these one. Documented coronary artery disease before, पहले patient का angiography हो चुका है. ST segment deviation is there or not. 2 anginal episodes in last 24 hours. Aspirin, whether patient was taking aspirin already for coronary artery disease, and whether cardiac enzymes are elevated. If person is having 0 to 2 risk factors, then it is a low category. You can take it easy. I mean, you need not to rush the patient to the hospital or to the cath lab. If there are 3 or more risk factors, it is an intermediate risk. And if there are 5 to 7, it is a high risk. Means you have to be absolutely alert and take immediate action. This is my last slide. Early identification of ACS can be life-saving. So we have to take a good history and a good physical examination. Simple. Patient comes to you in your clinic, please do have a good physical examination and good history. That will give you a lot of idea. Take a simple ECG and do the enzyme study. That will categorize your patient in what risk he is there. And once you have done the risk stratification, emergency cardiac care is required. And then suppose you are in your clinic, please refer the patient to the appropriate center where the patient can be treated. Thank you very much.
These kind of lectures are now missing from the most of the conferences. That's why they have still their utility, and it will be really for the physicians, and will be circulating to many social media. So it was a very useful talk actually. The basics, people forget the basics and go for direct angiography. They don't know how to diagnose sometimes. They just echo, ECG, tropi, HS tropi, ECG देखा भी नहीं है. So these are very important actually. These are basics of, this is what you learn in DM cardiology and DNB. And then only do. Thank you very much, Dr. Gupta, for giving us. Please be seated here. And we'll go for the next session, and then Doctor, you can be on the podium. Doctor. So the next talk will be by Dr. Nagendra, I think. He's Dr. Rashid Khan, I think, is still there from Pakistan online, Zoom, through the Zoom meeting. So we will have a talk by Dr. Nagendra Chauhan. Is he there? He's our friend from Vedanta Hospital. He's one of the directors now. And today he was supposed to come, but he had to leave to Amritsar so he says that possibly there was Tavi session or somewhere out of Delhi. So I requested him to be a part of this session still through the Zoom. This is the advantage of hybrid meeting, that you can still have people even if they are not on site present. So Dr. Nagendra, can you hear me?
Yeah, I can hear you clearly.
So he is doing a lot of good work. He's I would say that one of the middle-aged, not seniority wise, young, middle. I'm still middle. So then senior people like Dr. S. Gupta, he's one of those who are doing a lot of good work in Vedanta. Dr. S. Naresh Dehan is still keeping him. Otherwise, he would have moved to some other hospital. Okay, Nagendra, please go ahead with the talk.
Vivek, thanks for the introduction and thanks for inviting me to this meeting. I think it's a very interesting thing going on, and I also learned last 2 lectures and they are really interesting. So I move on to my present talk. This is basically on how the time is changing. So there are multiple unmet needs in cardiology we are facing today. increasing prevalence of arthrosis in younger patients we are seeing quite often, and unpredictable myocardial infarctions happening in so many younger populations, and we can't predict them and we can't prevent them. And patients who are already on medical therapy and on maximum drugs are still having ACS episodes, and there are unstable plaques and non-critical lesions. We don't know what to do. So there's a session on unstable plaques also in this session, so I'll not go in details on the plaque. But we have to understand that cardiology is changing very fast now. Initially, we were doing angiographies to detect coronary artery disease and do TMTs and all those tests, but now everything is changing very fast. Nowadays, most commonly we are doing coronary calcium scoring in younger ages who are asymptomatic, and then we are doing coronary CT angiographies, and we are supporting them with either stress or perfusion imaging. And nowadays, FFR CT is also available, which gives us a clear-cut idea of what to do for the patient for a chronic coronary artery disease. So this is without taking patient inside the lab, we can have clear diagnosis and idea what to do. So this is very important changing, but the major problem is the vulnerable plaque. We all know multiple facts that they are the culprits, but we don't know what to do for them. Although we are doing medical therapy, so I'll not go into details, but I will give you just a glimpse of idea. That this is a OCT image of a patient. It's like a histological cut section of a coronary artery, which gives a clear picture of calcium, thin cap atheroma, necrotic core. So you can see here, this is a calcified lesion, and this is necrotic core, very clearly seen, and then there is a ruptured plaque and acute myocardial infarction. So nowadays, imaging is so good that it can detect the lesion, but we don't know what to do in these situations. So we have seen multiple Minocas where the lesion is not significant, but patient had an MI and arteries are flowing fine. So nowadays, recently there is a trial published by the name of Prevent, which said that in patients with FFR negative lesions, if you find an unstable plaque, still if you fix it, it is considered to be superior to the medical therapy. So again, it's a new thing which may change the future guidelines, but we need more trials for this also. So with all these backgrounds, I will go into the tradition of teaching that what we do routinely for an intervention is if patient has a borderline lesion, the European guideline consider borderline for all patients with 40 to 90% stenosis by visual assessment. And all these patients ideally should be submitted for FFR if that's a chronic stable angina. And definitely in ACS patients, definitely culprit lesion cannot be assessed by FFR, but non-culprit lesion can be assessed by FFR, and then we can decide on the severity of disease and need for intervention, because the only 100% confirmatory or gold standard way of confirming the diagnosis for significant stenosis is definitely FFR. Only problem with FFR is it's only for stable coronary artery disease and not for unstable plaques. And actually patient is having problem mainly because of unstable plaques, and heart attacks are happening because of unstable plaques. So by FFR, we are doing interventions to prevent angina, but still we are leaving so many patients who are having unstable angina because of unstable plaques, and that's a major concern for us. So FFR, we all know, has multiple issues that is considered superior in terms of outcomes if we consider multi-vessel FFR and then compare it with CABG, but long-term outcomes are still comparable with CABG. So we are using FFR quite often in all the patients who are having borderline lesions, but all these technologies have their own fallacies and benefits. So we have to use all these techniques in unison. So like FFR is there for assessing the physiology, and IVUS and OCT are there for assessing the imaging. And now we know that we have to assess the tightness of the lesion, we have to assess the physiology, but we have to assess the anatomy and severity of the lesion also. So it's just a case-based discussion. So it's again a TVD with a angina patient, 63-year-old patient with exertional angina class C, diabetic, hypertensive, post-angioplasty to LAD, CKD on dialysis, had a TMT positive, now came with a TVD and waiting for renal transplant. And definitely there are patients who are already on dialysis and renal transplant and poor lungs. They are not very good candidates for bypass also. So in this patient, again, this was the discussion, though this was the angiography which showed that LAD was showing. So I will show you that. So this is an angiogram. LAD left main is okay. LAD, there is some plaque in the proximal part. OM is showing a tight lesion. Distal LAD has a tight lesion. OM2 has showing a minor plaque. So there are some plaques there, but this OM1 is looking like quite significant to me on angiography. And RC was looking even more significant. LAD was showing some 50% lesion in the middle part, and there is some distal 70% lesion. So LAD was not very tight, and RC looking quite tight, and OM is looking quite tight. So generally, this is not a classical case for bypass surgery clinically, so we thought we should do an IVUS. And again, patient was not a very fit candidate for surgery also, so we were discussing about the future management. So what is to be done for this patient with a triple vessel disease patient? So again, in diffuse disease and multi-vessel disease, it's always better to assess lesion individually for benefit of the patient, and then we can give them clearance for transplant kind of situation. So best is to do an FFR. So this was the initial plan, that we will do an FFR to LAD because the LAD is a borderline lesion, and then we'll fix the PTC, OM and RCA, and then patient can go for a transplant after 1 to 3 months depending on the urgency. So this was the FFR done to LAD, and this was quite surprising. At the distal part is 0.69, and in the proximal part is the mid part 0.79, 0.89, and 0.91. So this is quite significant, the distal part. But there was diffuse disease, so we were not very sure that which lesion is significant. So now it was thought that the mid part, which is that this is the long lesion, possibly this is causing problems, so this has to be fixed. So after discussing with the patient, and the patient was not very keen on bypass surgery, it was planned that we should go for angioplasty, and angioplasty was done and 2 stents were placed. So this was the previous stent which was placed previously, and now these are the places where there was IVUS was done, which showed some lesions. So we thought we should fix both of them. So IVUS was done, and these lesions were fixed. So this is, you can see that after putting first stent, FFR has gone down to some extent, and after putting second stent has gone down from 0.69 to 0.79, but it's still below 0.8. So although we have fixed everything, the FFR is not good. So is it FFR which is wrong, or are we missing something? So definitely in these situations, it's always better to have some kind of imaging which can give us a better idea. And we have done an imaging, and it showed us that at the left main, there is a significant plaque just before the stent, proximal stent in the LAD, which was done previously. And that was actually the culprit which is causing problem. And then the angioplasty to the left main bifurcation was done. And after left main bifurcation angioplasty, the FFR is really good. FFR came down to 0.94. And then the LAD was fixed, and then we have checked FFR for other vessels. So after fixing the FFR, LAD by imaging and physiology, we have checked OM lesion, which FFR was just 0.8. And RC again, to our surprise, FFR was 8.83. So both the tight lesions, which were looking quite significant initially, were actually not tight physiologically. And the most untight lesion looking anatomically on angiography was significant on FFR. But by guiding with FFR, we could not able to diagnose where the problem is. That ultimately imaging has helped us in diagnosing where the problem is. So imaging and physiology are actually complementary to each other. So finally, this patient got a angioplasty to left main to LAD and LAD distally, and OM and RCA are left alone. And then patient was kept on medical therapy for 3 months because there were multiple stents and previous stents and left main stent also. So we waited for 3 months. Generally, we wait for 1.5 months nowadays, but in this patient, we waited for 3 months for transplant, and patient went for transplant. So this is how this happens, that imaging and physiology are complementary to each other, and they can guide us how to decide in a difficult scenario what is the best for the patient and what is justified by guidelines. Thank you.
Thank you, Nagendra. Very nice and important talk, actually. And how frequently are you using in intermediate lesions FFR? I mean, almost 50% or 70%? Or would you like to do eyeball QCA?
70% or 80% we are using them FFR. So 50 to 80, 90% also we are using FFR nowadays. And almost all patients we are now using imaging also for angioplasty. Like even if patient has a simple lesion, for assessing the expansion and for assessing the size of the vessel and stent position, we are using IVUS in almost all of the patient nowadays.
Almost all?
Almost all nowadays, because we are using all the techniques, and we have 4 machines in our labs, and we could use almost all patients, although finance is a minor issue, but we could manage it by splitting the cost between multiple patients. So that's why we are using IVUS in almost all patients. What we do is we split the cost, we take a special consent from the patient that we can, either he can use a new imaging catheter or we can use a reuse catheter.
So the cost, I mean, sorry to interrupt you. I mean, the cost does not deter you from, because even our hospital being the most expensive hospital in Apollo, sometimes the cost...
Full cost to the patient. If patient don't afford, we split the cost and we make the patient sign a special consent that we can use the reuse catheter for them, and then we can split the cost.
So second question is, given that all the creatinine is normal and renal functions are okay, is OCT versus IVUS, which one would you choose? I mean, with your experience.
Very interesting and very important question to understand. Definitely, IVUS is basically important for sizing and
This is just for the learning and understanding. A lot of people will listen to your talk later on.
Basically is for understanding plaque morphology and complications. So routinely we use IVUS for almost all patients for sizing and stand position. And if we feel there is some haziness, some problem where we are not very sure that what is happening, then we use OCT.
So the cost is not a deterrent in your patients mostly. It's a good thing because you see the same thing is happening in, if you see a patient in France or Rouen, where I was working with Alan Kribier and Elena Shalinov, that because it is all covered by the insurance system, so they are having no problem in using such devices or imaging techniques because there is no patient they don't even ask the patient about the cost. So let us do with this. Same thing is almost happening in your hospital, I feel. So it's a good thing to learn. Thank you. And again, any question from Dr. Gupta? Dr. Vimal Mehta wants to comment. Yeah.
I'll say that, doing everybody ideally should be done, agreed. But it's slightly impractical in our, most of the labs are heavy, busy labs. But at the same time, having said that, for most operators, time to time on regular basis, they should do it because OCT and IVUS, they are teachers of angioplasters because they tell you that, visually where you are doing wrong. So they are self-deterrent kind of, and they teach you also that, I deploy standard, for example, somebody deploys 14%, oh, this look good. But you do OCT, you find that, it is underexpanded at many places. So you deploy 20. So from now on, you will start deploying at 20. So intermittently, one should, if he is not able to use for so many reasons, cost or volumes, one should be using it. I'm of that opinion.
I think definitely agree with Dr. Vivek. Although we see that we are very experienced operators, now we have experience of 10 years, 15 years, but every patient is different. If patient is obese, if tube is away, sizing is even also a challenge. Although sometimes we size that it's facility 3.5, and when we do OCT or IVUS, it's actually 5 mm in size. So sizing also is a major concern. Although we feel that we are quite experienced, but sometimes we are still missing. So it's always better to have some imaging which will give you objective evidence that this much is the size. So that way it helps you significantly in terms of long-term outcomes.
Thank you so much. I mean, it's all learning. I mean, we are using more of stent boost. We're not able to use so much of. Dr. Eskupta wants to comment something. Yes. Dr. Eskupta has a huge experience of angioplasty for last 30 years. So let us have his comment.
Poor man's imaging is
The stent boost.
Stent boost, which gives many times the idea. Of course, imaging is better, but poor man's boost is also good.
I think from now onwards, we should start giving, I mean, in Apollo Hospital, the package includes the one imaging, and then only it, because if you tell the patient does not tell you the cost, if you don't tell the patient the cost, it becomes so difficult. I mean, thank you, Nagendra. It's a good talk, and I will just show you. You stay behind, stay back. You are away, but still inside the hall, virtually. So I'm going to show you. Next, I would going to show you a small interview which I took with Dr. Carlo Di Mario, who's one of the stalwart of interventional cardiology. He was working in Royal Brompton Hospital in London. I visited many times, and now he's moved to Italy. I'm showing this video because I was talking to him about the vulnerable plaque, and this was recorded during one of the TCT meetings a few years back. So just for the interest of I have not heard this talk myself for a long time. So let me see what he spoke.
From New Delhi, India, today in San Francisco.
It's not coming. It's not coming. Okay, just a minute.
Tomorrow is the World
Just a minute. It should be. Okay, उस पे आ गया, ठीक है. इस पे भी आ जाओ.
I'm Dr. Professor Vivek Gupta from New Delhi, India, today in San Francisco. I'm working in Apollo Hospital, Delhi. Tomorrow is the World Heart Day, 29 September. Today is 28 September. So I am taking the advantage and privilege to be with Dr. Professor Carlo Di Mario, who is our friend and also collaborator for Indo-European Course of Revascularization. So the purpose of this video is to give a small insight to the Indian population or the world population about how to prevent the heart disease. You see this too much. It's the number one killer of the world population. The heart attacks in India, especially in Southeast Asia, is growing, with young people getting more affected, especially the males, but almost equally the females, the stress going up. So that's the three questions which I would like to take from the expert opinion. He's been professor in Royal Brompton Hospital. Now he's working in Craig Hospital in Florence, Italy. He is himself a legend because he has done a lot of research. He has been a pioneer in the stent studies, and then he did a lot of TAVI studies. I worked with Professor Alan Crepier in France. So, number one, I would like to give you some insights about the prevention of heart disease, especially the coronary artery disease.
Well, I mean, this is an international congress, so definitely this is not the main aim of this conference. Having said that, there was yesterday a very interesting meeting on assessment of vulnerable plaque, and I think we are coming together with several recent investigations confirming that we can identify plaques at higher risk. Today is published in the Lancet, the lipid-rich plaque trial, showing an increase in risk of events at 3 years that is double in the presence of a cholesterol content greater than 400 in a single position on a patient basis, and increases the risk from non-cholesterol rich to cholesterol rich plaque of almost 4 times. You may wonder whether this is sufficient to really go to local treatment of this vulnerable plaque, higher risk plaque. However, I personally believe that this is one of the steps forward that will become part of our current practice. When we treat unstable angina patients, we currently focus only on the culprit artery. We scotomize all the rest. From now on, we have the possibility to look at the remaining arteries, non-culprit lesion, and select patients that are at higher risk, who may require more aggressive systemic and local treatment from patients at lower risk.
So how do you recognize these plaques actually? Can you, for the public, for the people, simple people who do not know cardiology, how do they recognize? By angiography or 60 coronary angiography or what?
Unfortunately, angiography is not enough. The particular study I was discussing is based on near infrared spectroscopy, which is a technology not much diffused outside Japan, but there are other trials that are using optical coherence tomography, thickness of the fibroscope, dimension, extension of the necrotic core, and other trials that consider presence of macrophages, and all of them somehow are adding small steps in the direction of detecting features of
For the general public, the plaque which is 20, 30, 40%, which is not critical, it is not causing obstruction, it is not causing angina, the patient is fully hale and hearty, and these plaque rupture will lead to clot formation, and you have to control it. So from your horse's mouth, I would like to listen a little more about this prevention from the routine public.
Yeah, I'd say rather than in this Congress and in the European Society of Cardiology Congress, where the new guidelines on treatments of lipid disease and the new consensus document with the Society of Atherosclerosis came up with extremely low thresholds now, especially for LDL cholesterol. Now we've been a progressive reduction from 100 in the past to 70 currently the approved standard, but now in the last 2 months we should use 65.
So the LDL levels lie as low as 55
with the current treatment, and of course requires a step up in what we are currently using, combination treatment, the highest activity statins like rosuvastatin and ezetimibe, and in the future more and more use of PCSK9 inhibitors. The introduction, as you know, of the new RNA-based drug that works with administration twice a year, achieving apparent, so it's very early stage, similar results as evolocumab and nilokumab I think it is extremely promising.
So this is very important. What he has told is, this is very important that sometimes despite no smoking, despite control of diabetes, despite having a full cholesterol level, now we have come to the stage that not LDL level, which was considered to be 100 was okay, now has come to 70 and now 55. That means the reason why still these patients who do not apparently look like a high-risk patient, they still have the coronary artery disease, is because we are not controlling the LDL level to 55. Therefore, with a high combination of statins and other ezetimibe, as you said, should be given to all these patients. Thank you very much, Professor Kalutamani. On the World Heart Day, I congratulate everybody, especially the TCT organizer, Dr. Ted Stone, Dr. Martin Leon. And of course, you have been doing a lot of conferences. We hope to meet you soon in India. And we do enjoy your big course of revascularization, which is to be held in Munich in first week of May. I would like to invite you as one of the board directors. Thank you very much, Professor Dr. Vivek Gupta from San Francisco in the morning, 20th of September, along with Lady, and from the Boston Scientific Stall. I'm so happy to be pleased with Professor Dr. Mario to tell the people that how to prevent heart disease. Thank you very much.
So this was a small thing, okay, just to memorize, because I sometimes you take a sort of interview and you don't listen yourself. तो मुझे कहा मैं भी सुन लेता हूँ इस बहाने. Okay, so we move on to the next talk. You have to stay here. Dr. Anil Dhal actually was stuck somewhere and he will be coming on Zoom. Is he connected now? Dr. Anil Dhal? He just said he's connected.
I'm here. Can you hear me?
Yeah, I can hear you. Yeah, Dr. Anil Dhal will be talking about the new paradigm, occlusion MI. He said, I'll speak on OMI rather than AMI. So he will be talking, something, the next 10 minutes, he will be, something wrong with the audiovisual. Yes, Dr. Anil Dhal, very important, a senior cardiologist from Delhi. Please introduce yourself regarding your work and other things, and then please go ahead with the slide presentation.
Somebody allow me to share.
Sharing is there always in the Zoom. Down, more पे आता है उसमें.
No, I'm not able to share.
But you can always, there's always an option of sharing in Zoom because everybody is doing that. 10 minutes for the OMI. Then we will have a talk from Dr. Siddhant Rehan, young cardiologist, son of our dear friend Dr. Vijay Rehan.
Rejoin. I think I'll have to rejoin. Give me a minute.
Okay. So let us have it. Samir Kuba is here. Dr. Samir Kuba. Okay, you have the slides already ready here? Not ready. Slides. Can you give the slide? Okay, then Dr. Siddhant Rehan, please, your slides are ready. Please go ahead with the talk, and he will be talking of if CAG my only option. So you will get the CABG done, if that's the only option. If CABG, he said I will speak something like that. If CABG my only option, so I will do a medical treatment. Thank you. He is son of Dr. Vijay Rehan, who has been a professor cardiology in GV Pant. Now they both have moved to which hospital? Maharaja Agresane Hospital, and as his father, he is also doing some good work, and our dear friend Dr. Vijay Rehan's son.
Thank you, sir. Thank you for the lovely introduction. Just 1 second. Let me just find the slides. Have you uploaded it?
Vivek, I think I'll be able to share now.
No issues. Dhal sahab kar le pehle.
So Dr. Dhal, slides, you can share the slides now?
Yeah, I think so.
Okay, now you can see the slides. Please go ahead. Next 10 minutes as you are completely.
All right. Thank you for allowing me.
Dr. S.K. Gupta is one of the panelists. Dr. Vimal Mehta is another panelist, and there are people from Zoom from Karachi. Dr. Abdul Rashid Khan and one more. They are also one of the panelists of this talk of yours and session.
It's good to hear from Dr. S.K. Gupta after many years. Good afternoon, sir. Good afternoon, Vimal.
Deepak Jain from Germany is also connected. He's also one of the panelists and session and chair.
So I'm not going to waste your time. I'm sorry I'm not there physically, but we we know that cardiologists make a difference. We save lives. At least we think we do. But we've moved our paradigm from our classic definitions. I remember when we were doing our MDs, we used to have these long questions which we used to answer on Q-wave MI versus non-Q-wave MI. Then it became ST elevation MI and non-ST elevation MI. And now we've come to a new paradigm because we still miss a large amount of cases that we should urgently revascularize. So it does not matter whether our intelligence is human or artificial. What we need to do is we need to give timely treatment to our patients. And the Emperor Justinian actually wrote, names are the consequences of acts. So we all know that there is a series of changes which occur when we tie or ligate a coronary artery. And we all know that if we reperfuse this coronary artery, these changes may have another time course of action which could take us back. The point is that in this time course of action, we need to intervene at an appropriate time. Like I said earlier, we were concerned about having established Q waves. Then we were concerned more about having ST elevation. But now we all understand that if we look at these studies were inherently flawed because if 4 out of 9 studies required ST elevation, 5 required no ECG findings. And all this showed us the fact that if we intervene in time, as Dewood showed us in 1982, the first 4 hours, the first 4 to 6 hours are critical. 87% during an ST elevation MI or an acute MI will have at some time a totally occluded coronary artery. So at this time, we need to reperfuse. And if we really look back, if there is one indication for an angioplasty, it remains a primary angioplasty. Much after we have understood the value of lytics and primary angioplasty, we sometimes have undiagnosable cases. And we use the advantage of biomarkers like troponin. But yes, even troponin can sometimes mislead us. We know that highly sensitive troponin can be very effective. And now we have the advent of putting CT scanners right in the emergence. And they can actually do a quick CT coronary angiogram and tell us which is, especially in patients where we don't have classic changes of ST elevation or a Q-wave MI, we can actually use this. And this could be a new gatekeeper in acute coronary syndrome, because if we look at it, we may actually find vulnerable plaques, as was the previous interview with my friend Carlo. So if you really look at it, that we have these high-risk characteristics, which could be a napkin ring sign, which could be positive remodeling, spotty calcification, and a high attenuation plaque, which could discriminate between a vulnerable and a non-vulnerable plaque. But why this concept of occlusion MI? Because we could have less obvious ST elevation, we could have ST depressions, which posterior leads we know are not going to be represented on an anterior lead ECG, a 12-lead ECG. Some of the changes could be caught in the dynamicity of time. There could be hyperacute T waves. There could be changes in ST2 morphology. There could be terminal QRS distortion. And some people could have either a left bundle branch block or a paced rhythm. And we also could have some pseudo STEMI patterns. So a physician accuracy is going to be impaired. But it really matters, because if we can recognize this early, we will be able to salvage our patient's myocardium with reperfusion. Now, if we look at the STEMI, non-STEMI, the changes were because we were told that we should intervene aggressively and early in STEMI, but not so aggressively and not so timely in NSTEMI. You could wait the next day or so on and so forth. But this itself has been challenged, because your so-called NSTEMI may actually still have an occluded coronary artery, which may still benefit with reperfusion. And if we prospectively validate the current quantitative ECG criteria, well, you know that if you use a computer, as many people do, especially when they're out in the periphery, you know that the the positive predictive accuracy could be limited. There are 7 major findings among, say, 150 odd cases of where we had a clear-cut occluded coronary and an MI, which were picked up, which led to some issues with their diagnosis by cardiologists. This could be hyperacute T waves, pathological Q waves with subtle ST elevation, a terminal QRS distortion, reciprocal ST depression, and reciprocal T wave inversion, subtle ST elevation which does not meet the criteria but with some other features, and any amount of ST depression which is maximum in V1 to V4, and any amount of ST elevation in inferior leads with any ST depression or T inversion in AVL. So this was actually found to be the 7 most important things. But one ECG principle to remember is proportionality, because the larger the QRS complex, the larger is the T wave, and the same thing has to be kept in mind. So when we challenge the STEMI paradigm, we understand that it has diagnostic limitations, it has systemic inefficiencies and inconsistent protocols. It may have more false positives, and 25% of NSTEMI will have delayed detection of acute coronary occlusion, leading to more inertia by the team who is treating it and leading to loss of myocardium. So we have changed from Q-wave MI to STEMI, and now there is an emergence of an occlusion MI paradigm so that we don't miss these 25%. Now, if we look at it, how many patients do we miss? We actually miss 50% of patients with occlusion MI. There are 25-30% will be those with NSTEMI, where we don't have typical ST elevation. A couple of them will have delayed management as much as 15 hours later, where you know that there will be loss of myocardium. And there will be some 20% where there will be some STT changes with which there will be a false positive cath lab activation, which can actually deprive another patient of timely activation. Now, this has led to a lot of review articles all over the world. We know that Ajit Mulasari wrote an editorial last year in Circulation of occlusions, inclusions, and exclusions. And Emre Azlanger, who works with Stephen Smith, has written Diagnosing the Ominous. So there has been a recent review in JACC where it said from ST elevation to occlusion MI, and very clearly they pointed out that the ST elevation paradigm transformed emergency cardiology, but there is increasing recognition of limitations. STEMI is a poor surrogate marker, and if we look at evidence-based advances, and finally to move to artificial intelligence, we will then be able to identify all the appropriate patients so that there is timely activation of the cath lab and judicious utilization of the resources which are there in the world. Now, I must point out this particular criteria, this particular part of the slide, which says that if you are going to look at a STEMI which is diagnosed on ECG, a large number of them will definitely have an occlusion MI, and you can further confirm it with biomarkers or echo. But if there is only ST elevation, then we need to identify some ST elevation which may not have, say, a Q wave. And we all know hyperacute T waves, we know Deventer T waves, we know Wellen T waves. Now, there could be some ST elevation in 2 contiguous leads. And there are 2 patterns which I want to point out. One is called the South African flag pattern, and the other is the Azlanger pattern. And sometimes you could have a separation from pericarditis by ST elevation. We need to also separate it from early repolarization. In left bundle branch block, whether left bundle branch block which is degenerative or it is created because of a right ventricular pacing, we need to also identify, we have the Garbosa criteria, but we need to be able to identify correctly. And those patients who have pre-existing Q waves, we do not know whether they have reocclusion in the same territory, so we need to actually do this carefully. Now, like I said, from a Q wave, we move to ST elevation, and we are moving now to basically an occlusion MI. And if you look at it historically, we are all taught Q wave, Q wave, Q wave. Then Q wave, after reperfusion came into our lives, we were told Q wave is a completed MI. So therefore, we were focused on STEMI. By the time there is ST elevation, no Q wave, we should intervene. But now with artificial intelligence, new tools coming up, we need to reperfuse appropriately with good new quality indicators, and new research will obviously happen. So what are the steps in dealing with this? Firstly, exclude artifacts. Secondly, exclude secondary depolarization like a left bundle branch block, maybe a pre-excitation or hyperkalemia. Exclude other causes of secondary ST elevation like a left ventricular hypertrophy, and exclude like pericarditis, early depolarization should be considered. And once you've done that, and this is in patients with obvious ST elevation. Without obvious ST elevation, we look at some specific pattern, especially posterior MI, Devinter pattern, and these are something which you can do. So look at some of these. So these are some artifactual causes of ST elevation. There is a low atrial, or what is called a Scherf rhythm, which is causing an apparent ST elevation in 2 and 3. There's a flutter wave, which can be mistaken for an ST elevation. You can have an electromechanical association artifact. You can have an ST elevation because of high pass filter being set and using a manual mode. And then you look at depolarization abnormality, which has to be distinguished from appropriate discordance or not. So larger the QRS, then we look at the direction. And here is a patient who had a 73-year-old man, 6 hours of ischemic pain, and there is a history of aortic dissection. Now, if you look at this ECG, what are we finding? There is a new right bundle branch block and a superior axis, which is associated with a proximal LAD occlusion and negative outcome. And therefore, this is proximal LAD here was 100% occluded. So now then you look for other causes of ST elevation, LVH, interventricular conduction defect, old MI, aneurysms, and any other cause. And frankly, we diagnose pericarditis at our own peril if somebody actually comes to the ER and saying, because very often we will miss inferolateral MIs with circumflex or right coronary occlusion, but it is never will there be a reciprocal ST depression in AVL with pericarditis. So here is a patient, atypical chest pain. Now, if you look at it, there is widespread ST elevation. Now, it was misdiagnosed as pericarditis, but it was actually an LAD occlusion. But if you look at the fragmented QRS and low voltage in V2 and terminal QRS distortion in V2 and V3, these are all clues of an anterior MI. Now, pericarditis, myocarditis, Takotsubo, Brugada, sodium block channel blocking drugs, pulmonary embolism, early depolarization, and Minoka can all simulate this. You can have ST elevation, but with negative T waves. And this can actually happen with either with pseudonormalization, or you look at the terminal T wave, and this we clearly know is something which you call the Wellen syndrome. There are two patterns, a terminal T wave inversion or a symmetric T wave inversion, which are type A is early reperfusion changes, and type B is late reperfusion changes. So you can also look at terminal QRS distortion without S waves, without J point notching, which can also be quite significant. And this can again be something which you can take as a criteria. Now, I have over 100 ECGs here. I don't want to do that. So I just want to make you run through. When there is no obvious ST elevation, you look at hyperacute T waves. Now, here we thought that this was somebody came in with chest pain. But if you look very carefully, look at the inferior hyperacute T waves with negative hyperacute T wave in AVL. And I think this is important. The lateral leads also have minimal ST elevation and hyperacute T wave. This was occluded right coronary artery. Sometimes T wave is going to be disproportionate to QRS. So all this has to be kept in mind. Truly an isolated posterior MI.
Sir, actually, I have to be devil's advocate, and we are running almost an hour late.
I will not take you through the ECG.
So maybe it will be great if you conclude. And do forgive me for interrupting you. It was really wonderful.
No. I just wanted you to point out, here is the South African flag sign, in which you will probably get minimal ST elevation in 1 AVL and T inversion in lead 3. And then if you look at V2, now this is quite typical of maybe a diagonal occlusion. And I will just bring you back here. There are some mimics that you need to look at. I've already pointed them out. And the truth is that all this has been put by us and by a lot of other people in the world into AI packages. We have a couple of AI projects which are going on this to diagnose occlusion MI. And this is what is going to make life very, very easy There is a real world demonstration of an occlusion MI, and this is how it actually functions with this AI model. It scans these portions, the typical portions, and once it scans, it correlates. So in a normal looking ECG, also we had a diagnosis of a true positive, and here is a what looked like there was a real world diagnosis which was true negative here, and therefore this is all being put together in very good software, very good
Sir,
application
yeah.
can be seen
So
on your phone.
your points are very, very clear, and
I conclude.
believe it or not, I 100% agree with you. Do you correct me if I'm not in one line? You are saying that every patient who is suspected ACS, I mean, should have a coronary anatomy known, because EC change in some patient may be, over-diagnosing, but for most part, they may under-diagnosing the occluded artery. I mean, which the patient can benefit
I
from
think we need to
reopening.
improve
So
our-
basically, we should know the coronary anatomy in most patients. You mentioned about, CTs in emergency and all that. So I fully agree with you. We should know the anatomy. That is the message you want to give. Either it is by AI algorithm or,
You are missing the
ideally
point.
by this.
The point,
That's the
point, Dr.
yeah.
Bimal, is
So-
that
so
we
we-
need
we
to
have
be
to
little
improve.
better in ECG reading. We
Yes.
need to correlate it. And today
Yes.
by AI, we can actually have what we miss as humans, as even though we are experienced cardiologists, we can also miss, but that can be put by, so some people have done a lot of work on this, and even the subtle changes have been incorporated in
Yes, but
AI
ultimately,
algorithms.
at least gist of stories, you will have to confirm it, sir. I mean, I agree. AI will be there in every. I mean, trying to take our jobs. That is there, but till that
AI is
occurs,
helping us in our job. It is not going to take away our
no,
job.
it is not. But in some areas like radiology and so on, it may be the case. Nevertheless, let's not get into controversy. Professor Vivek Gupta sir will, give the final comment. But your talk was very, very, exciting and, yeah. So to summarize, so we need either AI algorithm, and ultimately, basically, we should not totally rely on ST elevation or ST depression. That you want to say. We have to see subtle signs. We have to, we have to know the coronary anatomy better so that we can treat, I mean, diagnose our patients better, treat them better in a more, appropriate manner. I agree with you. I could not agree with you more. Thank you so much for a wonderful talk, sir. We are really behind the schedule, and we must move forward. Yeah.
Dr. Dhal has given a fantastic talk on OMI, and I just want to say a hello to my friend again, Dr. Mansoor Ahmed from Pakistan, who's joined. We have back-to-back sessions, and there are people who are waiting. So I'm requesting actually for some change in the schedule has been requested by Dr. P.K. Ashokan and Dr. Deepak Jain. If you just wait for a while, stay here. We will have a talk by Dr. P.K. Ashokan and then Deepak Jain and then yourself and Kuba, Dr. Kuba. So don't, because he has to go somewhere, he cannot do from the car. Dr. Ashokan, please go ahead with the next 7 minutes. We are squeezing the time of the speaker because we are running late. At 7 p.m. our chief guest is the guest of honors will start arriving. So we have to finish by 6:30. So 6 minutes or 7 or 5. Dr. Ashokan, I can always tell him he's a friend.
So first of all, let me thank you for giving this slot. So actually, the calcified coronary as distinct to Dr. Chavan and Dr. Anil, now we know that is the role of imaging, the role of artificial intelligence. We are discussing everything about the recent trends.
Dr. Dhal, please stay back. Yeah.
Calcium, the prevalence of cancer risk factors is, that is increasing linearly with age, and is majority of the people up to 80 years, you see some sort of calcification, and it's more common patient with circadian diabetes, hypertension, and high BMI, obesity, a patient with inflammation, family history of CAD. We see, do the imaging, 73% of patients will see the calcification versus CAG is a 48%. Most important thing is, if there's a calcification, coronary calcification, impaired the stent delivery, and HD even stent expansion, and leads to the under-expansion and lead to the complications that we are going to discuss later. See, the angiographically invisible calcium is thin calcium, does not inhibit stent expansion. That's the most important thing. Most important one is a calcium volume, that is thickness, angle, or length. And the calcium fracture is a key mechanism for good stent expansion. And if we see the calcium modification, atherotome lithotripsy facilitate calcium fracture even in the calcium and results in good stent expansion. These are transient. If you see the fluoro, and if you see this type of calcium both sides, even without a cardiac cycle, that means it's a we are dealing with a severe calcium. And if you see the imaging, you will see the calcium, which maybe we can quantify the calcium, whether there is a superficial calcium, deep calcium, or whether there is any calcium nodule, or is there any severe calcification. Calcium is quantified by measuring the arc it encompasses. Calcium is classified in location that we already discussed, as superficial or mid, deep, or depends upon the arc. It occupies 180, 270, or 360 degree calcium. And you see the calcium severity depends upon the calcium scoring. If it's more than 270, and if it's occupied, say, you see the thickness is more than 0.5, or length is more than 5 millimeter, we consider it is a severe calcification, and score invariably will be more than 2 in this case. If there's a calcium nodule and vessel diameter less than 3.5, we are dealing with the patients with a severe calcification. And these are recent publications in actually showing that it's compared with the angiography and the imaging guided PCA is, and the outcome is better, not only immediate, long-term outcome. And based on these, that is complex anticoagulation studies, and that is IVAS expert studies, and that does. And we know that is a reason the guideline is changed in all complex intervention, and intravascular imaging is a class 1 indications rather than class 2A, that is in 2021 guidelines. So I was imaging, intravascular imaging in coronary, identify calcium stent phenotype, location, and guides calcium modification strategy, may optimize calcium stent deployment, which reduce the event rates. And augment the device for the PCA in calcified lesions. We can use the specific devices like specialized balloons, atherotome devices, or lithotripsy. And if you see that NC balloon, usually we use if there is a mild calcifications or moderate calcification. In the same situation, you can use a cutting balloon or angiosculpt. If there is a severe calcification, atherotome or IVL is recommended. So if we say eccentric calcification, in calcium marker less than 180 and calcium thickness less than 0.5 and calcium length is less than 5 millimeter, we are dealing with the mild to moderate calcification. In this case, NC balloon, cutting balloon, scoring balloon is indicated. And if it's a constant calcification, a calcium mark is more than 180, thickness is more than 0.5, calcium length is more than 5, then where atherotome or lithotripsy is indicated. In nodular calcium, depends upon the lumen area, we have to use the devices, either atherotome or IVL. This is the case of elderly late. You see the radial lesions in the osteodetion, and it's a little anomalous origin, high origin. What should be the things here? You can see the calcium specules at the ostium, and this is what we are dealing with the IVS, this is nodular calcium coronary. So we use the JR catheter here, and this we use after that is pre-dilated lesion of 1.5. Use the imaging. There's a HD IVS, and you see that is here, and there's a calcium node to the proximal portion, but the lumen area is more than 5.5, and you see coming to the ostial region. Here you can see that is a calcium nodule here, put into the lumen, and where the MLA was 1.8 here and here. And so what should be the strategy here? And here in this case, we used here the MLA is 1.8, and we used here the IVL here. And you can see that IVL balloon and shockwave guns, that is used the 3 into 20, 3 into 12 balloon. And here this outcome here. You can see that the calcium is fractured and this is standing. And this well expanded portion here, the ostial portion, where we got a area is around more than 10.3, and this is the final angiography. What I want to say is, whenever there is even the ACS patients, We are suspecting the calcification, and if we are suspecting the calcium nodule, imaging is mandatory. And when you compare the erratic calcium with non-erratic calcium is usually protruding calcium, and you can see that is irregular lumen, usually associated with thrombus, where you get immediately outcome is good, where you get a valve area, you get a circular lumen, but long term you get a more ISR, more event rates. But if it's a non-erratic calcium, where immediate outcome may not be that good, and we may get an elliptical lumen, but the long-term outcome will be better in non-erratic calcification. In both conditions, if vessel diameter lumen area is less than 5.5, then only it will intervene here. And we see that IVS versus IVL in both conditions, you can use devices. And here in erratic calcium, mostly is deformable calcium, greatest in expansion, that's we already discussed. But in long term, it is usually accessed to the higher ISR when compared with the non-erratic calcium. In both the things, you can use the NC balloon, IVL, atherectomy. But in non-erratic calciums, you usually use NC balloon and both IVL as well as atherectomy. And IVL advantages of IVL limitations is easy to use, maintain the multiple guideways and potential fracture formation, deep calcium. Effectiveness is larger lumen, and you need to use 1.1 balloon and lower risk of vessel trauma. And here is a case where you see that this LAD lesion, consider the middle lesion, and angioid there's a calcification. And see this IVAS, again you did HDL IVAS, and it's not working. I'm not going to the still film then. And where you could see that this concentric calcium here and lumen area is 1.8. And in this case, you used superficial calcium concentric calcification, and the calcium score is more than 2. So here you use the rotation 1.5, and we got a reasonably good result after that. And see here, and the post test I was run. There are some problem. Okay. And this outcome we achieved. So we get optimal stent expansion, and there is short-term and long-term we expect in this group of patients a good result. So atherectomy in coronary lesion applied to moderate severe calcification, choice between rotation or orbit atherectomy, both the device deliver similar outcome and practical points for the device choice. So if you use the orbit atherectomy, usually is good for the large vessels, proximal lesion, non-tortuous lesions, and where the ischemia during the procedure is less when compared with the orbit atherectomy. Orbit atherectomy is good for in large hospitals, the smaller vessels, and if there is a more tortuous lesions. And
sorry, sir, to interrupt you. Actually,
the last one.
yeah, if you will be kind enough to conclude, sir.
This one, as angiography evidence of coronary calcium, you do the imaging to evaluate the criteria for calcium modification, and use the intravascular imaging, not feasible, and if not able to cross the lesion, you can predilate, then you can go with the atherectomy devices, and unable to deliver, and you use the atherectomy, and if you're able to cross the lesion with the balloon, you can use the two options, IVL or atherectomy here. So calcium fractures on IVL, if you do repeat the IVAS, intravascular imaging, and if there's a calcium fracture, and if there's a NC balloon, there's a full expansion after using the device, then again proceed with the PCI. If it's not there, again you can use the other devices like say NC balloon or opening this high pressure balloons, or even devices, modifying devices here. So
sir,
calcium,
sir, can you conclude in one line or so?
Have been associated with suboptimal PCI in the outcome, and intravascular imaging combined with a stepwise algorithm approach to lesion preparation may improve outcome. Atherectomy devices have historically been the backbone for the treatment of calcified coronary lesions. Intravascular lithotripsy, atherectomy balloons, laser, or high pressure balloons have expanded the treatment landscape. Thank you.
Thank you, Dr. Ashokan, for a very nice demonstration of talking about calcified artery, which has, of course, day, and it's a real problem for all of us. Actually, now, since we are running late and we have a valedictory session to start at 6:30 onwards, Dr. P.C. Rath is already there. He's a president, or now past president, or still the president of CSI, my good friend of ICR since beginning and from Hyderabad. We have 4 talks before Dr. Rath, and we will request everybody to be precise 5 minutes. I'm sorry for that. 4 slides initially, 4 concluding. Siddhant is looking at me. I'm sorry, but the thing is that we have to really conclude, and there are people from Germany. They will be coming up later on. So, Deepak, can you wait for a while, or you would like to do? Dr. Mansoor will have a final discussion later on. Dr. Deepak, he wanted to go somewhere. He has got to Sunday, and the Germans are always. He's become German now. He's my DM batchmate, of course, but working in Apollo early. Dr. S. Gupta is doing the panel chairperson in this session. So, Deepak, can you just give 6-7 minutes only? I'm sorry for that, but yeah, very quickly we can start Dr. Deepak Jain's slides. He wanted to go. He requested me before Dr. Ashokan. Then we'll have Dr. Siddhant and Dr. Samir Kopa, and then we'll move on. So, Deepak, we'll be having a quick, because it's nice to see you after a long time. We have been coming and talking. So, the topic will be what you are going to talk about. Protected PCI with Impella.
Can you see my screen, Vivek? Can you see my?
I can see everything. Just quickly, I'm requesting for a little quick initial 4 slides and final 4 slides.
Okay, let me quickly go through it. So you want me to show it in 4 slides?
You can.
Sir, I mean, the gist of the story is humbly requesting to be brief, because we have been, delayed, and, chief guests are due to arrive in an hour or so, and we will be, really stuck up sort of. So we need your genuine and help, most humbly. So maybe you can show 8-10 slides and conclude, because your topic is in any case very exciting, and we need to learn from you also. Please, sir.
But first of all, you introduce yourself also. What are you doing there in Germany sitting, coming back to India or not?
Okay, Vivek, let me first show you a couple of cases. I think I'll not show you slides. I'll just show you some cases. And just to show you prototype examples of how we can use Impella in different situations. Protected PCI basically can be used in 3 situations. In doing cardiogenic shock, for example, this is a case where we did a multi-vessel PCI. The patient was under constant resuscitation on Lucas, and we did Impella, a combination of ECMO and Impella in this patient. So a 46-year-old gentleman who presented with pulseless electrical activity, 60 minutes of ongoing resuscitation, and during the ongoing resuscitation, we did a multi-vessel PCI. And how Impella was helpful is one thing I wanted to show you. So the first stenting in the intermediate artery, and then recanalization of the L6, a stenting in the L6.
No, we're not moving your slides. Actually, your slides are not moving. You put on the slideshow.
How should I? It is slideshow.
Actually, we are just seeing one slide of yours of the Impella protected PCI, the introduction with your name of MD FSCC. Yes.
Yeah.
Now it started moving, but you put on the slideshow. It's not slideshow.
This is slideshow. This is the. Can you see it now?
Yeah, we can see moving now.
Can you see it moving now?
Now it is stuck at hemodynamic support equations.
I don't know why it's not moving. I have no idea. Because now is it moving?
No.
On my screen, it's moving. I think it's a problem at your place. It's a problem at your end.
Could be internet issue. Could be internet issue. Nevertheless, sir, maybe we heard you that you did this. The fellow was pulseless for 60 minutes, resuscitated on Lucas, and you did Impella. Maybe you can continue from there, sir. I mean, it is very interesting that
Dr. Vimal Mehta speaking from. He's a professor in GB Pant Hospital.
Yes.
The thing is, if you cannot see the films, then. Can you see the film now?
I think you can unshare the slide and share again. Let us try once more. Stop sharing and then share again. Yeah, it has moved again. MBPCI on Lucas.
Yes, we can see, but this is not moving actually. I think this is internet issue.
yours, share. Okay, let me show you the entire screen. Maybe that works. Can you see it now?
But it is not.
Can you see it now?
Sir, we can see the slide, but you know your video, what you want to obviously show us is not moving. Maybe
Yes,
yeah,
now-
no, it is moving.
This
Yes.
is slideshow now.
Stenting of the left main, stenting of the LED and L6, and tracing angioplasty, and a pot in the left main, and a good result. So in cardiogenic shock, Impella has a very special, a very special indication. This is a case of diagnostic angiogram where there was a young Filipino sailor who came to Germany during his expedition, and what we saw was a high grade left main stenosis. And before we were doing a complete angiogram, the left main occluded. So quickly, introduction of Impella and a multi-vessel PCI, stenting, and a reasonably good result. Rest of the vessels, the patient insisted that he'll get it done in Philippines. Another example of bailout angioplasty. Let me just skip that. Now, now let me show you. I showed you in cardiogenic shock. Let me show you a couple of elective patients before we run out of time. There is this multi-vessel angioplasty with a retrograde recanalization in an ejection fraction of 12%. You will see the LV, the RC is occluded, and the LV is severely reduced 12%. And in this, we could do this multi-vessel angioplasty, including a retrograde CT of the RCA with Impella without any problem. So a stenting of the LED first, and then antegrade recanalization attempt, but the wire was going into the false lumen. So a retrograde attempt, externalization of the wire, and then a routine angioplasty of the RCA. Let me quickly go through it. And this is the end result. Did a dilatation and pot of the LED, and this is the LED. So with an ejection fraction of 12%, we could do. Now this is an interesting example of how a hematoma can compress left main, and how Impella was very helpful in this case. So again, a case of left main angioplasty with a chronic total occlusion of the or subtotal occlusion of the LCX. It was actually a CTO with bridging collaterals. So we did an IVUS, we saw LED did not have that amount of calcification, but the L6 had a lot of calcification. We did a simple angioplasty of the LED, and then did a rota of the L6. And then at that point, we saw hematoma at the left main here, balloon dilatation, and stenting of the L6, and the hematoma increased, and suddenly the patient decompensated. There was hypotension, and what we saw was a left main compression. And this left main compression was because of the hematoma. So we quickly did a stenting of the left vein, and then we continued with the angioplasty. We realized that the the hematoma is arising from the ostium of the LCX. So we did a cutting balloon, we did a covered balloon at the ostium of the LCX. And then we did a routine left main angioplasty with bifurcation, involving the bifurcation. And all this could be done because impella was there and the patient could be managed. In the end, the patient was hemodynamically stable and could be discharged on day 3. Again, an example of how impella could be helpful. I'll show you the last case. Probably we are running out of time. So a quadrifurcation which could be done with impella, a left main quadrifurcation with a chronic total occlusion of the LCX. So first, integrate recanalization of the intermediate artery, or the second intermediate, if you would like to call it that way. And then I tried an integrate recanalization of the LCX, but it did not work. So went retrograde through this tortuous collateral here into the LCX. As you can see from the RCA, this collateral was extremely tortuous. And we could go retrograde, we could come retrograde into the L6 ostium, and then we did a wire flagging and did a recanalization of the LCX. So then balloon dilatations of the L6, stenting of the first intermediate artery, crushed stenting of the second intermediate artery, again here, and crushed with the left with the balloon in the left main L6. Finally, the LED L6 stent crushed, and then the LED continuing into the left main. Was the medial LED, and then the LED continuing in the left main. So then after putting in 4 stents, we could pass 4 wires again, and then did a tracing balloon dilatation, as you can see here, and this was the end result. So all this could be done with impella. So impella basically is very useful. I have a lot of cases, but I think I would like to end here. Impella has indication in both elective and cardiogenic shock patients. In cardiogenic shock, it improves mortality and operative easiness. In elective patients, you can do multivessel angioplasties, including left main bifurcations, trifurcations, quadrifurcations. With reduced ejection fraction, we have done ejection fractions of 12%, as I showed you, and all this can be done because of impella. Thank you. I think you're running out of time.
Beautiful cases, sir. Beautiful cases. I mean, these cases prove that you are master of masters. But only one quick one-liner, answer requested. So, what is your threshold for using impella, and who pays for impella? I mean, we would like to use impella much more frequently over here. I mean, obviously we deal with a similar kind of, profile, sicker patient, out of hospital and so on. But impella is a, very expensive kind of proposition over here. And who pays over there? So it's, I believe it is state sponsored over there. So you don't have to worry about the funds. Is it true, sir?
Yes, there is 100% insurance in Germany, so money is never a problem. The insurance pays for impella to the hospital. The patient doesn't have to pay anything. So because the 100% patients are insured, this financial consideration is not with us. So we only see the medical indication of an impella, we do it.
So thank you, Dr. Vivek sir, Professor Vivek sir.
Yeah, so Deepak, nice representation. I mean, Dr. Asgupta is sitting and smiling as usual. We are not able to have that liberty of having expensive devices like this, and that's why we are not able to use it. That's the advantage of France and Germany, where everything is covered by insurance and you are able to save lives. We also save lives, there's no doubt in that. But we would use take our old friend balloon pump in such cases, and we still come out of it. But it's good to know and learn. You stay back. We have quick 2 lectures. Dr. P. Sirath, I would like to request you just stay back for 10 minutes more for a quick 2 talks which are pending here as per the line. And Dr. So may I request Dr. Trehan, Siddhant Trehan, to talk in 5 minutes. If CABG is my only option, then he will go for medical treatment. No, but he has to speak something else. Slide laga inki. I was just joking, yeah.
I think following Dr. Deepak Jain, it becomes quite easy to be talking about is CABG my only option or not? Because considering the cases that Sir has just shown, I don't think anybody needs CABG. So we do have operators there. So anyway, so to my topic today is going to be, is open heart surgery my only option? And I wanted to start with a small case where there was this old lady, 87-year-old, diagnosed as triple vessel disease, advised CABG at multiple centers. So we want to revascularize to increase her life. But at 87 years old, do I want to subject her to an open heart surgery to extend her life and give her so much pain, or maybe not? So we can still continue with medical therapy. I think it's not lost, that it helps in relieving symptoms, slows down the disease, and we have newer metabolic modulators which help in improving symptoms without decreasing heart rate or blood pressure. We need treatment for such patients because as the disease increases, coronary artery disease in terms of severity and the number of arteries, mortality rates go higher. And we know that medical therapy does not help with mortality benefit, but revascularizing with either bypass surgery or angioplasty definitely helps. So when we talk about revascularizing, it's not just that putting in a stent or putting in a graft. We should look at the angiogram, try to assess what sort of revascularization is needed, the myocardial bed which is involved, how much is the actual level of ischemia, and how much are we going to benefit the patient with revascularization. So what is the best strategy? Should be something which is not invasive, no risk, quick procedure, quick recovery. There should not be any long-term medication. There should not be any chance of recurrence, because now we don't have any of these things. So we're either going to subject ourselves to an open heart surgery, which would be something like this, or an angioplasty, which would be something like this, where the patient walks out the next day. So now we all know that bypass surgery has been there for the longest time. It was the one which started revascularization. But since the 80s, when we developed Lima to LED, there's not been nothing new which has improved outcomes, other than just the fact that, our ICU care has gotten better, we have better outcomes. Still mortality is around 2 to 2.3% even at best centers after CABG. Angioplasty, interventional cardiologists initially used to just do an angiogram, provide the CD to the CD or the films which used to come back in the day to the cardiac surgeon and discuss with them that this is the point of grafting and this is what is needed for the patient. But over a period of time, as the armamentarium for cardiologists increased with newer devices, newer stents coming in, drug-eluting balloons, imaging, interventional cardiologists started to take on more and more complex lesions. So complex lesions are the ones where multiple arteries are involved, multiple stents are needed, there's left main disease, tortuous arteries, calcifications, chronic total occlusions, and patients who have a low ejection fraction. Standard risk in PCI is less than 0.5%, but it increases as the complexity increases. So in CABG, it is preferred for complex lesions because the complexity of anatomy does not matter to the surgeon, because surgeon really needs to see if the patient is fit for surgery and if the patient has good targets. But while complexity increases the risk for PCI, which makes the risk more or less similar. There are not a lot of operators, Dr. Deepak Jain sir is definitely one of them, who do such complex cases, and they do it with a relatively high level of safety. Bypass surgery is done in a controlled and cool environment. In the OT, the heart is stopped, every patient's on the vent, and the surgeon has time to work around it. Perks of PCI would be it has low risk, early recovery, mortality rates are similar, it is not limited by comorbidities as such, there is a lesser chance of stroke. For bypass surgery, it's much cheaper, it's not limited by lesion complexity, chances of repeat revascularization are less, there's also a lesser chance of bleeding, and also in case somebody has a valvular heart disease, it can be taken care of at the same time. But we're still left with some scars of CABG. So in an ideal scenario, the patient should have a heart team discussion. Each and every patient should be individualized. The anatomy should be properly assessed. The comorbidity should be looked at. And most importantly, we should ask the patient for his own preference. Usually what happens is the consent has been given by the relatives and not by the patient himself. Even though now hybrid strategies are coming up, but it will take some time. Now there's a concept of CHIP PCI, which was shown quite well in the last presentation as well. Here the patients are high risk and the lesions are also extremely complex. And because in such patients, risk is very high for both PCI and bypass surgery, unfortunately, these patients don't really have any answer for them. But it should be offered to patients. The only reason it's not offered is because less centers, it needs dedicated training. There's specific hardware and specific training for such hardware. It needs a lot of experience. This does reduce the risk, but it does not completely, totally remove the risk at all. Unfortunately, problem is the cost. Like the Impella in India costs around 25 lakhs, and there's a very handful number of people who can actually afford that. So the roadblock with complex PCIs, despite this being available, there's a lot of lack of awareness amongst most people that this can be done. People count number of stents. They don't look at complete revascularization. Angioplasty has come a long way. There's been a lot of development with imaging, rotational atherectomy for calcium modification. We have better stents. We have drug-eluting balloons. Results now are as good, if not better than CABG. But the ugly truth is that a lot of people still lose their lives because they have an advised bypass surgery, which they are too scared of getting, and they don't really know if they have any other option. So what did I do for that patient, that 87-year-old lady? I assessed her angiogram. I saw that one artery, the main artery, was supplying around 60% of the left ventricle. It had a complex, long calcified lesion. I discussed with the patient and the attendant whether she could take antiplatelets, and she had no risk for antiplatelets, and she was also taking aspirin previously. So we did an IVIS guided rotational atherectomy to her LAD and left her LCX and RCA on medical management. The patient's been doing well for the last 6 months. So the take-home message is bypass surgery is not your only option. There is no standard of treatment. A heart team discussion should be done. Treatment should be individualized to the patient's needs and his or her personal preference. Most of the cases can be managed with new techniques and new hardware. Unfortunately, there is a cost. That is the single slowing down factor. Thank you. I think timing is okay.
Yeah, thank you so much. And now over to Professor Vegupta sir, and sir will.
Thank you,
maybe
Siddharth.
invite the
Very
next
nice.
speaker.
I think Dr. Askripta want to comment something? Give the mic to him. Mic.
It's about in surgery also. I don't know whether the people are doing nowadays. Minimally assess. You can put a graft to LED, and that's enough. It will carry the life on. No, I'm not talking of hybrid. I'm talking of doing only single graft to the most important art. And that's it. Patient, if LED, Lima is working to LED, patient will not die of heart.
Good comment, I think. We can have a before Dr. PC Rath. You want to comment something?
Nice talk. Thank you.
Okay, so Dr. Samir can have a quick talk about 5-7 minutes regarding cangrelor, which we have started using a lot. This is a short-acting intravenous antiplatelet. Dr. PC Rath is waiting. After that, he will give a talk on that was the presidential oration. That will be something like that. So, Dr. Samir, over to you on cangrelor, which is intravenous antiplatelet.
So I'll just skip through. So this is a drug which is an IV antiplatelet. The beauty of the drug is its onset of action is extremely fast, within 3 to 6 minutes. It's completely reversible, and the effect lasts only for 30 to 60 minutes. So it's an ideal antiplatelet in many scenarios. Now we know the limitations of oral drugs. Patients who are in cardiogenic shock, patients who are persistently vomiting, patients who are too sick, patients on morphine. These are the patients in whom the absorption of oral antiplatelets is a problem. So IV antiplatelets are required. GP2B3 inhibitors have been excellent drugs, but they increase the risk of bleeding, and their onset of action, though fast, their offset is slow. So some patients may die because of a bleeding complication rather than a thrombus. So cangrelor is an ideal drug. And this is the dose which has to be given at the time of PCI, and it's very easy in the...
He should have been invited earlier. Our friend, Dr. Kundu to be on the panel, please.
So basically, this is a bolus followed by infusion, very easy to use in the cath lab. You have a chart on the board and your technician can do it for you. If you need to use ticagrelor, you can use it at any time, but if you need to use prasugrel and clopidogrel, it should be given only after the cangrelor infusion is over. So cangrelor should be given ideally for 2 hours or the duration of PCI, whichever is longer. Very suitable for patients who are persistently having nausea, vomiting, receiving morphine, intubated, cardiogenic shock. The oral antiplatelets, will not act in them. So these are some of the trials. I'll skip that in the interest of time. But there is also an entity of bridging this drug. If suppose somebody requires a CABG, suppose you've done an angioplasty, patient is on dual antiplatelet, and for some reason or the other, he requires a CABG early, some complication. or something. So, I mean, you can actually try to stop the prasugrel about 7 days back and clopidogrel and ticagrelor around 5 days back. And after 1 day, you can switch over to the infusion of cangrelor, which can be continued till the time of CABG or any other surgery, and just discontinued 1 to 6 hours prior to the surgery. So that is the beauty of the drug. You can actually give the drug, you can stop the drug, you can take care of immediate complications, and the onset is so fast, the offset is so fast that the complications, even if they happen due to bleeding, the moment you stop the drug, the effect is gone. So I'll just show you 1 or 2 cases. This is the now recommendation that it's a class 2 drug, not a class 1, but the issue is it is very good anti-ischemic agent, anti-thrombotic agent, and the risk of bleeding is very, very less when compared to the other agents because the offset is very fast. So it should be considered as a significant improvement in the antiplatelet efficacy, especially with the IV drugs, and our usage of GP2B3 inhibitors has almost become negligible now. So who benefits the most? This is a very important slide. Patients who are ACS spared from a preloaded DAPT. Sometimes you take the patient to the lab. I had a patient today with 2:1 AV block, anti-wall MI on the ECG, but the angiogram was absolutely normal. And the patient has a sclerodegenerative heart block, although the troponin is high. Patient who is clopidogrel resistant, patient who has to undergo an immediate CABG or a non-cardiac surgery, CHIP cases, patients in whom GP2B3 inhibitors is a problem, a sick patient who is in cardiogenic shock, persistently vomiting on morphine, you cannot give the drug. So I'll show you 1 or 2 cases. This is a very sick patient, anti-wall MI, cardiogenic shock, very, very sick, LV function 18%. We do not have the luxury of using Impella or something, so we actually took the patient by giving IV cangrelor bolus aspirin through the Riles tube and took the patient to the lab. You see his ostial LAD is completely occluded. The right coronary artery also has is mildly diseased. And this patient was taken up for a bifurcation angioplasty. And as you can see, a left main to LAD stent was put. And patient actually was given an appropriate pot. And finally, the result was pretty okay, although he had a distal diffuse LAD disease, but the patient did survive. He had a complicated course. He started to have some bleed in the ET tube, developed sepsis, decay, antibiotics were hiked up. This was the ECG, but patient gradually stabilized, and after 5-6 days, he was home and he's doing well. This is another case who actually presented to us with a non-ST elevation, acute coronary syndrome, delayed presentation, multivessel disease. You cannot do much by angioplasty. He has a significant disease in all the arteries. The RCA was also 100% occluded, filling retrogradely via collaterals. And you can see the RCA on the right side. It's 100% occluded right coronary artery. Diffusely diseased. So we had to do a CABG for this patient, and the patient was put on IABP. And so the beauty of the drug is that the CABG could be done next day because there was no oral P2Y12 receptor antagonist given, and patient cangrelor was stopped, and then patient underwent a successful surgery. This is a third patient who was very anxious, came with persistent vomitings, was vomiting whatever drugs we were giving to him, and he had an LAD occlusion, a lot of thrombus, finally required 2 stents, and we did IV cangrelor usage in this patient. So such sick patients can do very, very well. And that is the final case. This is a patient again, severe anti-wall MI, LV function 15%, cardiogenic shock, saturation you can see on the monitor 59%, severe LVF, bad ABG, started on inotropes, intubated in the CCU. We put the femoral sheaths in the CCU before taking the patient to the cath lab, because sometimes what happens is you take the patient to the cath lab and there is no pulse. So you do the puncture as early as possible. And this is the angiogram. You can see a left dominant circulation, 100% occluded LAD, and the right was non-dominant. We did a thrombosuction, IV cangrelor, and finally we took a lateral view also just to make sure, and this is the LAD. You can see grossly thrombus laden, but we did not use any GP2B3 inhibitor. Cangrelor was sufficient enough with thrombosuction, and finally you can see it's a beautiful result, and patient did well. He had a chest X-ray issue, he had some bleeding, but finally he did well. He was discharged on aspirin and ticagrelor. So ladies and gentlemen, I just want to tell you about this molecule, that if the patient is very, very sick, patient is not able to absorb the antiplatelet drugs, patient is in cardiogenic shock, patient is intubated, patient has a complex PCI, a CHIP CTO PCI, giving this drug is very, very beneficial. The effect is phenomenal, and the beauty is that the bleeding risks are relatively less as compared to GP2B3 inhibitors, and another beauty is if you stop the drug, the effect is just gone. So thank you very much for your patient hearing, and I think I have adhered to the time.
I have just one quick question. So let's say some patient comes, you have to take him up and you do not have time. So will and you plan to do cangle management, want to give infusion and all. So will you load the person with some other antiplatelet also? I mean, any another drug like clopidogrel or ticagrelor or prasugrel, and also give this one also simultaneously, because it is said. I mean, though this is a little bit controversial, but for example, clopidogrel has the active compound remains in the blood for 30 to 60 minutes only. So if it does not find, I mean, we give it as OD dosage, right? So if it does not find, and it will block the receptors, platelet receptors for, indefinitely kind of. So if it finds the receptor blocked by some other agent, and so it won't be effective.
So the answer to
I
that
mean,
is,
so yeah. So what is the practical tip kind of?
yeah, so the practical tip is, if the patient is antiplatelet naive, he has presented to you acute MI, give him aspirin, give him cangrelor. Okay, do the procedure. Once the PCI is over or 2 hours have elapsed, now you can give him clopidogrel or prasugrel. If you want to give ticagrelor, you can give it at any time, even when the cangrelor is on. So if the patient has come, you want to load with Brilinta or ticagrelor, you can do that. Use IV cangrelor simultaneously. But for clopidogrel and prasugrel, it should be given after the cangrelor has been stopped.
Yeah, as you rightly said, so you have to give a gap of some, so that receptors are now open
Yes.
to get attached to the clopidogrel molecule or prasugrel molecule. With ticagrelor, yeah, as you said, I mean, so that may be the case. Okay, thank you so much.
So Cangrelol, are you using in GV Pant Hospital? Are you using it?
Sir, very rare. Actually, cost is an issue over here. Though we do use it, but
It's not that
relatively
expensive. What,
infrequently.
8 to 10,000 rupees? Yes.
Cost is, I think, 3,000-4,000 rupees. How much? 6,500. So 6,500 is the cost. So that it becomes a little bit.
I personally feel that sometimes you have platelet resistance. You don't never
Because
know.
in my hospital,
Especially if you're planning a complex angioplasty, it is give a, if not actually, morally, no, sorry, psychologically you get, okay, we have done a complete inhibition, something like that. Before you give, even those patients who are on ticagrelor, and there are few percent of patients who will be having platelet resistance. And when you're doing a complex long stents, I think there is a good reason to use it. That's my thought process.
yes, anything from outside is practically prohibited actually.
Okay, so we have continue this. I don't think we'll have time for the coffee breaks, but we will go for a quick. Dr. P.C. Rath is already here, and he's our friend, and he's a senior cardiologist, Hyderabad Apollo. He's doing a lot of work. He did a Hyderabad Valve conference. He is associated with ICR since 2008. Always been there with us when Dr. Creeper and we started. He was a co-director with us, and dear friend, and he's been the president of Cardiological Society of India. So this is what he's going to talk in next 15 minutes. Interventional cardiology in India, past, present, and future. So he will talk what has gone through in India, Indian perspective, how interventional cardiology grew in India from the beginning. And panelist is Dr. A.K. Kundu and Dr. Vimal Mehta. So chairpersons. So please go ahead, but I would request you to be, because after that Dr. Host Sievert will be speaking from Germany, and he will be talking about PFO closure program in India, very interesting. So I would like to just stay back for a while. And Dr. P.C. Rath said 30 minutes, so I will request that if you can skip few slides in the interest of time, it will be a great honor to have your presence. Thank you. Dr. Rath, please.
Thank you, Vivek, for inviting me to participate in this beautiful meeting. Chairpersons, Vivek asked me to talk on interventional cardiology in India, past, present, and future. Actually, this lecture I gave it during my presidential oration in Lucknow CSI conference. So I edited it to some extent to suit the time, 15 minutes, 20 minutes. He told me first, now he wants 15 minutes. He wants me to tell the history of 40 years of interventional cardiology in India in 15 minutes. Okay. So the first after Andrei Grunjic started did his first angioplasty in 1977, there are a lot of excitement amongst the cardiologists all over the world. Few cardiologists from India also, they went to USA, Europe, attended some course, saw some procedures, and came back and started this in India in 85. I was doing my DM that time, just entered DM in CMC Vellore 85. And as a young student of cardiology, that this also was, it created a lot of buzz. And all the students that time were thinking, okay, we finish and go and do the training from somewhere and come back and start the intervention program. I started up in 87 CMC Vellore. I started with balloon mitral valvuloplasty, then renal angioplasty, then 87 coronary.
Your slides are not moving. Have you started moving the slides?
Without seeing anything. So that is the starting of my intervention program. And this presentation is basically based on literature research, hospital record, newspaper clips, and personal communication, because most of the things were documented, not documented, initial cases were not documented well. So the PTCA in India started in 85. First, I think in Delhi in AIMS by Dr. Manchanda, and in British Candy, Dr. Bailagani started. In Calcutta, Dr. Mantosa Panja started. In 86, in British Candy again, Samuel Matthew started in British Candy and Apollo Hospital. In NIMS in Hyderabad, Somraj did the first primary angioplasty, and starting GB Pant by Dr. Khalil and his team in 87. In 88, myself and my Professor Kishan Swami, we started the PTCA program, and that was the first program that was through the brachial artery. I think that was the first angioplasty in the world through the brachial artery, which was not again published. AB Mehta started in Jaslok, and also started in 40s and 80. From 85 to 90, there was a lot of meetings. First, PTCA registry was started. It was the first registry meeting was in Hinduja Hospital. Then the registry started. Matthew was the first convener. And the first live demonstration was Jaslok Hospital, Mumbai. Dr. Gerald Dorans came and they did some 23 cases. And first publication of PTCA was from AIMS by Upendra Kal. That was published in Indian Heart Journal in 89, and 2 years follow-up PTCA down there. Then some course started. Kasim, who was working as in a device company as director, he took a lot of interest, and he started this angioplasty teaching course. Started in 90, and it was supported the BARD company. That time Kasim was working in the BARD. And said, AB Mehta, Somanaj, Matthew, Gambhir, Upendra, all actively participated. This is one of the meetings. And this was used to be a formal 5 days course, teaching course, with very few, around 30, 40 people who were interested in learning these techniques. And very personal interaction, a very nice course. Most of the international cardiologists who are the senior cardiologists in India practicing, they came out from this course. Dr. Alan Tibir started the Indo-French course, and this was his brainchild. He was coming to India and he was coming to Hyderabad. We started Indo-French course, and through this Indo-French founding Indo-French foundation, through this, lot of Indian cardiologists were sent to different places in France for training. PTCA then came this, there was a cardiopulmonary support devices that was developed by Saul from Washington, and that device was for a very high risk patients like impala and all that. That was done in first case in 90 Jaslok Hospital. First bare metal stent came in India in 91. First bare metal stent was performed by Purushottam Lal in Apollo Hospital, Chennai. That was published in Indian Heart Journal. And primary angioplasty elective coronary stenting series was published by Gambhir in Indian Heart Journal in 95. Then, of course, there was a series from AB Mehta group also. Kalam Raju stent was developed by doctors Somaraju, and the first case was implanted in 96 in Medicity Hospital, Hyderabad. And I did the first transradial coronary angioplasty in 94 in the Hyderabad Hospital. Then came the atherectomy devices, and Ashok said it 92, the first directional atherectomy devices, rotational atherectomy devices. First few cases were published in Indian Heart Journal by G.S. Gambhir. Then it moved, and first left main coronary angioplasty was done by Gambhir, and the series was published by Gambhir in Indian Heart Journal in 98. So slowly people started doing complex interventions involving left main. Then the Spittish alternate route was looked in, and the two alternate route was radial and ulnar. I started with radial, but I suddenly did one ulnar. One patient which I couldn't do the radial. I thought of doing ulnar, so I did the first case in 97. This was published in local newspapers. I sent it to Indian Heart Journal. They rejected it. That was the first case in the world. Subsequently, I did the first angioplasty stenting with transulnar approach, and the series was published, Percutaneous ulnar approach for coronary angioplasty. It was published in Indian Heart Journal. The first publication was on ulnar interventions was in 2001, whereas I did the first case in 97. The first DES came in 2000. I did the first DES in 2002 for a young patient or a lady, and that time DES was not available. The patient's brother was working in Paris. He carried one DES, and I implanted. Then came the era of transradial coronary angioplasty. This in 2005, Tejas Patel and his group published the first series of transradial angioplasty and in acute MI, and I published the coronary angiogram intervention through transulnar approach in 2005, and then Tejas Patel and his group again published a large series on transradial interventions. Tejas Patel and Sanjay Chuk should be given the credit to make this transradial interventions popular in India. Tejas Patel started this TRICO meeting, which was very popular. Many of the people attended. He published 3 books on transradial interventions. And Sanjay Chuk also used to conduct a radial life meeting since 2005. And he also edited a book on transradial interventions. I contributed in both books. Then came the era of imaging, and interventional ultrasound was there. OCT came, things were more clearer, and in 2000 onwards, a lot of image-guided PCA was being performed. I did publish the first series of OCT-guided PCI in India, published in 2014. That time Impella also came. Also did the first Impella in 2007. Then came the STEMI interventions became popular. Thomas Alexander should be given the credit to popularize the STEMI India through STEMI India, and this model was adopted by ESC and ACC, and this is a very proud moment for all of us because he has worked very hard to popularize this STEMI intervention in India. Then lot of in between 200, 2000, 2020, lot of new techniques came in and disappeared. One of the techniques, PTMR, this was percutaneous transmicral revascularization. We used to do it for patients who are not suitable for revascularization, diffuse disease, and all these things. Some symptomatic improvement, but subsequent trials showed that it is not very effective, so it went off. Intracoronary radiation came for instant restenosis. We had beta cath, we had gamma radiation, I all did it, we all did it, many centers started, again it disappeared. After stent came in 2012, I did the first case. In September 2017, it disappeared. Then, of course, we have this yeah, that drug coated the Merrill company, and they have the Merrill stent, which is observable stent, and that is showing promising result. And this 3 years clinical data was presented by Ashok Seth in Euro Interventions were published, and this is we should look forward for this device for the future, because I think this is and one magnesium coated magnesium bioabsorbable stent is there, so they are making slowly inroad into our practice. A lot of device 2020 onwards, lot of devices came for calcium manipulation like IVL, orbital arthrotomy and laser. And there also came zero contrast PCI, robotic angioplasty came in. I also started, but company discontinued. Only one company now is working on this from France. We do not know what is going to be future. And the shock trial that was from India, that was presented in Europe this year. Ashok Seth presented on behalf of this shock trial investigators. That was very good from India. Lot of meetings were responsible for popularizing this coronary intervention for teaching and training. And NIC meeting is very popular, started from 88 onwards, every year it is being done, and most of the youngsters participated in live cases, and it's the best learning meeting in India. BBIC started in 2008 Indo-European Revascularization course, and I think this is the 21st meeting. Both he's doing it very regularly, both physical and virtual format. This is the 21st meeting, and thanks Bibin, he's getting a lot of international renowned international cardiologists in this forum, and it's helping a lot of cardiologists to learn more about the new techniques. Of course, India Live started in 2010, IGCTO, Chief CTO, two of the dedicated imaging meeting were skipped, and Imaging and Physiology Council of India started in 2017 and 18. Of course, this is the PBX meeting, 2008 started, I was there, Karan KBL, and it was a very beautiful meeting in Delhi. Subsequently, he had this meeting in London, Zurich and Paris, back to EA, and this is the 21st meeting. Congratulations, Vivek. And interventions is going very fast in India. And in last year data, 2023, it is 31% increase in participating centers, and now more than 1,000 centers are performing angioplasty all over India. And a lot of centers, almost more than around 45% of patients have imaging facilities also, and you can see 44% both have got imaging facilities. Some 10% patients have centers have both intravascular ultrasound and OCT. However, penetration is very low, maybe cost or physician's inertia. IBAS is done around 6.3%, OCT in 1%, FFR is around 2%. I think it's going to increase in future, but very, very underutilized. The total number of pipeline PCI done, I just wanted to tell you that this is the number, 6,55,000 in 23. But this is around 20% centers have not participated. So industry data tells that it's more than 10 lakhs now in India. 2023, more than 10 lakhs coronary interventions is being performed in India. In USA, the data it's around 10 lakhs, and the whole of Europe is around 10 lakhs. I think with the way we are going, in 1 or 2 years, we'll overtake USA and Europe. But China is far ahead. I think we'll be second. China is around 1 lakh 30, 10 lakhs to 13 lakhs, 14 lakhs, they are doing the interventions. So we'll probably be the second one. The device I've already told, primary PCI is increasingly becoming more and more. Almost 20% of the interventions are in acute MICTs. So more and more centers are taking up primary PCI. Calcium management, all the devices are being used, and compared to 2024, the number of devices used has gone up to 40%. But IVL, cutting balloon, laser, rota, all these things, because I think we are doing more and more complex cases. That's why the calcium devices, calcium management devices are increasingly being more useful. Balloon mitral valvuloplasty in India started in 85 in GB Pant and AIMS. Dr. I think same day, Peter Block he's the person who came and started it, J. Locke, and he is from Boston. He came and same day he did it in GB Pant and AIMS, and this was published in NEJM. Subsequently, we started initially when we started, they used to have two balloon, who were together, double balloon technique. Subsequently, balloon came in, and I started using bifocal catheter, which was basically a single balloon catheter, single catheter with two balloon, and then came metallic commissutum. So some of the landmark publication on balloon mitral from India was there's a I already told you about the NEJM article that was published on mitral valvuloplasty initially 85 from GB Pant and AIMS. And then Indian Heart Journal 93, Satyavan Sarman group published the first initial experience with 200 patients with balloon. And from CMC Vellore, Dr. George Joseph did the first case and series of BMB through transtubular approach. And I did the largest series of valvuloplasty with bifocal catheter that was published in Catheters and Cardiovascular Diagnosis. Then came the mitral commissuration with lot of hope, because this is metallic valve, metallic devices, it can be reused, and because it was very ideal for third world countries. That time we had a lot of mitral stenosis, but cost was a real concern. And with that idea, we have developed this. The first cases was done in Hyderabad with me and myself, and what Keeper did, and that was published in Lancet. Then subsequently it was published in circulation, the multi-central trial started, everything started, but the company, medical company, was a French company, was supporting these devices. They backed out because mainly because of financial reason, because they thought that because it is reusable, so it was not economically viable. So that was a premature end to the dream of having a device for the poor people where the procedural cost will come down. And this was not in the mind of people when he developed. And with that time, we are focusing only to develop a device which can reduce, cost will come down. But that aspect, that bringing down the cost too much, is not going to be cost viable for a company. That never stuck to us. So the company didn't manufacture this anymore, and end up it comes out. Then a lot of these devices mostly started in AIMS, GB Pant, pulmonary tricuspid outing valvuloplasty, all because Dr. Professor Khalilullah started the Department of Interventional Cardiologist and promoted all coronary valve peripheral interventions, and all these pulmonary tricuspid balloon outing valve, everything started in GB Pant. Now we are mitral all over. The last statistics show that we are around 8,500 we are doing plateaued now, and we are seeing less and less number of mitral stenosis. I think it will slowly come down. Pulmonary aortic tricuspids are being done wherever it is necessary. Renal angioplasty again started with TAGI in GB Pant. And initially only balloon, then stent, then cover stent, and that's now being routinely used. Carotid angioplasty first was done in Simsibolo by George Joseph in 96, and I published a series on carotid artery stenting with filter protection. And the last series that came out from Dr. Mullah Seri and their group from Madras Medical Mission that was published in 2008. 2021, I did a case of calcific carotid artery stenosis. I did it with intravascular lithotripsy. That was the first case in India that was published in Indian Heart in 21. Autoarthritis was very specific of India, and a lot of work is done here. And mostly it was Sanjay Tyagi and Dr. George Joseph, and two textbooks were published, one by Dr. Mantosh Panja and one monogram by CSI, edited by Sanjay Tyagi. These are autoarthritis publications. Are largest publication was by George Joseph in JCC, and this is very specific of India, so we have a lot of publications on autoarthritis. Then aortic aneurysm, I think large publications from George Joseph from CMC Vellore. So this is specifically repair of fenestrated aortic endograph repair, and this is just published in Circulation Journal of Endovascular Therapy. Very large series in CMC Vellore of aneurysm repair by George Joseph. Pediatric interventions, the first Ruskin which is basically percutaneous intervention procedure. It was done in 1970 by my professor, Professor I.P. Kumar, late I.P. Kumar, and subsequently A.B. Mehta did it in 74 in Jaslok Hospital and Bombay some hospital, I don't know. EST devices, PDA closure, or BST closure, everything was done again first time in the GB Pant Hospital by Ramesh Arora, Khalilullah and team, mostly by Dr. Ramesh Arora. Some of the landmark publications on pediatric interventions. One is device closure for sinus venosus by this Madras Medical Group by Shiv Kumar and his colleagues, and this was published in American College of Cardiology Journal. And other is a catheter bus-based front-end completion without parasurgical preparation. This is a very novel technique, and this was published with Muthu Kumaran from Apollo Chennai. And this is from Hyderabad, Dr. Nageshwar Rao. Here devised a specific Punar, but the VST for the VST closure that is undergoing multi-centric trial. And we have a large series of experience with my valve for the RBOT to be used in RBOT with multi-centric trial. Shiv Kumar and all this Muthuraman and Shiv Kumar all are participating in this. This was published in Annals of Pediatric Cardiology. Structural interventions started in India in 2004. Associated with the first case with a core valve in a patient with severe AR. And the first published few cases also said, and his group first Indian experience was published in 2013, and subsequently 2018, Sundar Balu and his colleagues from Madras Medical Apollo Madras, they published a large series from their experience of the Indian Heart Journal. So my tractive, the first one again, associated in 2018. Now total number of mitral cape is done. So more than 400, around 500 now. Total center which has been performed is more than 64 in India. The first publication came by sites, it is from Apollo Chennai. Here they have good large number published in Indian Heart Journal. So the TAVI in India, roughly we did in 2023 around 2,000 cases, out of which majority were by valve. and others were different valves. And that was the number we have in 2000. It's growing, I think, compared to 2022, there's 30% growth. And we have three meetings. India Bharat started in 2017 by Ashok Sen, Murugan, Changat Balu, and Praveen Chandra. And we started in Hyderabad, Hyderabad Bharat meeting, which is very popular. 2019 we started. We had 2 months back at this meeting, we had a record number of live tumors, 23 cases. And there's another meeting, Sai Sati organized Sentinel meeting in Chennai. The future, I think, number of PCI in India will overtake that of USA and Europe, will be next to China. Precision PCI is going to the in thing. It's all guided by imaging and physiology, and it will be driven by artificial intelligence. Metal-free PCI is going to the future in 10 years. Only 20% will be DS, others will be either DCB or by adapter strained by or BBS. Emphasis will be more on aggressive secondary prevention. Impeller devices size is going to come, already it's available now, 9F impeller devices is going to be sponsored, easy to use these devices. Again, PCR tower, structural intervention tower number is very small in India. I think it will go faster after price of the devices come down. And I also wanted to emphasize the fact that genetically, we don't see that many degenerative aortic stenosis that are seen in white population. Genetically, I think we have got less degenerative aortic stenosis. Low profile tower devices are coming. 9F is already on the way. And the whole idea is to get down the line to make the size smaller and smaller to 8F. Durable valve is going to the future. One valve, the life this valve will be going to durable, one life for one valve. That genetic engineering is going on this aspect. Future devices will have the access for coronary, because many of these patients will require coronary interventions. Future device will have easy coronary access. Dedicated valve for mitral and tricuspid positions are being evaluated. Thank you very much for your attention.
Excellent talk as usual, Dr. Rath. I just wanted to know from you, what is your feedback? I really want you to stay back with the host. Stewart is already here. I think he's there. Yes, Dr. Stewart is here. We wanted to have a coffee break, but I think we can have a coffee break after your talk.
Okay, perfect. Thank you very much. Sorry for the delay, but I had an emergency, so that's why I'm joining.
So we have so fantastic talks coming all the way from Germany. We have a panel, Dr. Vimal Mehta, Dr. A.K. Kundu, and myself, and Dr. Host Stewart. Can you introduce you a little more? He is doing he's one of the very important eminent cardiologists, and Dr. P.C. Rath, who is the president of Cardiological Society of India, is already there. He just gave a talk on the past and present and future of interventional cardiology in India. So you have to introduce a little bit about yourself, and then we have next 10 minutes with you. And before we go for a coffee break in India, of course in India, yes, you're in Germany. So PFO closure program in India, why to start? It's a very interesting talk, and Dr. P.C. Rath and Dr. Vimal Mehta will have the feedback after this. So introduce yourself a bit more than what I can do, and then you go ahead with the talk.
Okay, so I'm interventional cardiologist based in Frankfurt, and working in the structural field a lot, but also in peripheral coronary, stroke, and everything else from head to toe. And when you invited me to talk at your conference here, I thought maybe a simple thing like PFO may be of some interest, because that's actually the entrance door to structural interventions. And I'm assuming that many of you, or many of the attendees, maybe not of the faculty, but of the attendees, are doing mainly structural. And so PFO could be something to consider when you want to get engaged in the structural field. So most or all of you know, of course, that PFO can cause embolic stroke, and this is well known from case reports since 1877. And there was a German pathologist in Berlin, Julius Kronheim, who described the first case, a post-mortem case of a young woman who had a paradoxical embolism. There was huge evidence for PFO closure from non-randomized trials and initially conflicting results of the randomized trials. And these were actually the initial randomized trials, Closure 1, Respect, and PC. And you can see there was, in all of them, there was a relative risk reduction for further strokes, but the difference was not significant. So all these trials were named negative, although in the Respect trial, risk reduction was 50%, in the PC trial, risk reduction was 80%, but again, they did not reach significant differences. Then everything changed in 2017 and 2018. 4 new randomized trials came out, all of them had been positive, and this had an enormous influence on clinical practice and guidelines. These 4 new randomized trials have been the Respect, that means the extended follow-up of the Respect trial, the closed trial, Reduce, and Defense PFO. Finally, after we started PFO closure 25 years earlier, so after 25 years, we finally had these positive randomized trials. And this is one of the meta-analyses of these trials, actually of all trials. And you can see that in all these trials, including the both negative trials initially, the overall stroke risk reduction was 40 to 90%, and that created level 1A evidence for PFO closure. And what is important here, anticoagulation in these patients is not an alternative, because in the control group, all these patients had been treated either by anticoagulants or by aspirin Plavix. So medical therapy is not an alternative in patients who are suffering from a stroke due to a PFO. Now, this is now the summary of all these trials, the randomized trials, and you can see here on average 61% risk reduction. So after these randomized trials, we should not diagnose a cryptogenic stroke anymore if the patient has a PFO. Instead, these are embolic strokes due to a PFO. PFO closure is highly effective in preventing strokes. Anticoagulation or anticoagulation is not an option anymore. Now it is clear that patients do benefit from PFO closure not only after decades, as assumed in the past, but already after a few years, because all these trials had only a follow-up period of 2 or 3 or maximum 4 years of follow-up. If you start a PFO program in your center, impact for your community will be much more important than due to a TAVR or MitraClip program, and I will give you some more information about that. Usually when I present this elsewhere, I've presented this in India before, the answer is usually, this is India. We do not see strokes in young patients. We have other problems. We are dealing with more important diseases. We are dealing with life-threatening diseases. There's no reimbursement for PFO closure. And also PFO closure is boring. We want to do more interesting procedures like TAVR and CLIP. And I will go through these arguments against starting a PFO program one by one. So first is, we do not see strokes in young patients. Well, you should see more than you do. And there is a lot of literature showing that actually stroke is a very important disease in your area of the world, and that actually the annual stroke incidence among younger patients is absolutely comparable, if not higher, than in Europe or North America. So actually you should see many young patients with strokes, and also the embolic stroke of undetermined sources is very important in your area. There's high prevalence of right to left shunt in these patients. You should see many patients with strokes, and there's more literature. I cannot go through all these details here because of time issues, but you can see actually embolic stroke, PFO associated strokes, or PFO strokes caused by PFO is actually something which you should see very often. You have 1.4 billion people in India. The annual stroke incidence among individuals below 50 years of age is 46, as we have seen, 46 per 100,000. In India, every year, 64 strokes below the age of 50, and more than 20,000 patients per year with a stroke due to a PFO. However, less than 100 PFO closures, to my knowledge, are performed per year in India. So it's a very lack of awareness and underreporting and a big field to develop, actually. Another argument I hear is in India we have other problems, 100% agree, but none of us can solve all problems of the world. We have to start somewhere. Each of us in his field, and our field is interventional cardiology, so this is our call or your call to fight against these diseases. Then I hear very often we are dealing with more important diseases. Well, this is our youngest patient where I closed the PFO. This was also my youngest patient whom I performed a cerebral embolectomy. This is immediately after removing the clot from the brain. This was the clot in the middle cerebral artery. And of course, the only potential cause of a stroke was a large PFO with an interatrial septum. And I closed this later on. And if she gets another stroke, she may spend the next 6 days in a wheelchair. So this is actually a very, very important issue. Also, when you think about what is the risk of a recurrent stroke in a 16-year-old girl with a large PFO and septal aneurysm, look at these data. This is, I think, from the RESPECT trial. 8% after 3 years. So this is those patients who are randomized to device closure, and these are the patients randomized to medical therapy, and you can see that they have a very high risk of recurrent events if you do not close the PFO. And what would you think if this would be your daughter? Is that something important or not important? I think all of you will agree this is indeed a very important issue, much more important than aortic stenosis in elderly patients. Please tell me, which disease is more important than a stroke in a young patient? A 3-vessel disease in a 70-year-old smoker, aortic stenosis in an 85-year-old patient, mitral regurgitation in a 75-year-old patient with severe heart failure. Well, all these diseases are, of course, very important, don't misunderstand me, but are they more important than the stroke in this 16-year-old girl? Then I hear there is no reimbursement. That was always the case. Think about PCIs. I don't know, maybe 20 years ago, there was also no reimbursement in India and in most areas of the world for PCI. The same, there was initially no reimbursement for TAVR, and maybe still there is not sufficient reimbursement. MitraClip the same. And as you know, life itself starts without any reimbursement. So the argument there is no reimbursement is not valid. Then I hear PFO closure is boring. We want to do more interesting procedures like TAVR and MitraClip. Well, I'm sorry, but I can't really help you with that one. Although failures and complications occur, so if you have done many cases, you will get many referrals after failed attempts elsewhere. So if you start early, you will be the leader in the PFO field, and you will have more complex procedures, even with PFO closure. So the answer is yes, you should start a PFO program. Yes, in India, not today, of course, but next week. And how to start the program? Team up with your neurologist, establish a bubble test in your center, because many of these patients are not even diagnosed. The bubble test means echo with contrast. And come to CSI, our conference, of course. Ready, steady, go. So this is our next conference in Frankfurt, CSI Frankfurt, end of June. And I hope I will see all of you there. Thank you very much for your attention. Are you still there?
That was a very, very interesting talk, actually. So may I say, ask sir, I mean, at a practical level. So let us say you have an individual, and you incidentally happen to find that the individual has PFO, but no history of any TIA or any any suggestion of any TIA or stroke or something. So how do you go about it? I mean, how will you approach this fellow? You do contrast and you see that yes, PFO is definitely there, but obviously, so from practical point,
That's a very advanced question. I mean, we are not there yet. We are still, even here, we are still working to detect all those patients who had a stroke due to a PFO. So to close PFOs which are diagnosed incidentally, we are not there, but I think we have actually good data in the literature that we should start a trial to look whether big PFOs with septal aneurysm should be closed before the first event. And now, since we have all these positive trials in those patients who had an event, we are approached by patients who say, well, I have a sister, she is 10 years older than myself. She has a PFO, she had a stroke, and I have the same. I also have a PFO, but I don't want to wait for my first stroke. And I say, currently there is no reimbursement for that in Germany and no data yet. But I think it's worthwhile to consider a trial in this patient group. It's actually not the patient group, it's a group of individuals who have PFO.
Yeah, I agree, because if we start doing them, I mean, we will, the numbers of PFO closure will increase exponentially. I agree, because all these device closures, I mean, they do have, I mean, theoretically, there can be some complication or something. So it has to be, risk-benefit ratio kind of situation has to be there. So Professor Vivek Gupta, sir, will take over and sir will.
Thank you, host. Very nice presentation. I know that we have been suffering. I mean, I know the one of the incidents in my family that a PFO gave rise to stroke coming from DVT. So that is that's why it's very important to have such programs.
Yes. And sir nicely pointed out, we need a randomized trial, but this a trial of will have to be of huge magnitude. Actually, I don't think such a trial will ever occur, because it will be costly, considering that the incidence of stroke in an asymptomatic person will be relatively quite low, even if it be a PFO. So maybe you will require 20, 30, 40,000 patients to be followed up for maybe 7, 8, 10 years. So
let's concentrate on those patients who had a stroke, because the evidence is clear.
I was talking who didn't have stroke. I mean, So it's practically not a practical thing, perhaps. Nevertheless, sir, what a wonderful talk from you. It was great listening to your wonderful talk, and thank you so much, sir. I mean, with that, over to Professor Vivek Gupta, sir.
Dr. Host, can you stay back for a while, because I'm going to speak upon TAVI on a Kribbear type of a symposium, Kribbear symposium. Dr. Alan Kribbear, we lost recently. You are aware of it, that, and I have been working with him earlier a lot, and very affectionate to me personally. So you stay back, and I will speak because I have to give this talk, a very important talk, which is a TAVI in general, bedside to bedside. So transcatheter aortic valve implantation. I'm going to speak. Dr. P. Sirath should be joining. He said he will be there. Dr. Kundu and Dr. Vimal Mehta is here. It's my very important topic, close to my heart. I worked with Dr. Kribbear in 1996 to 1998. And that time it was a idea in his mind. But he was working on that, but he did not disclose that things are coming soon. But he told me that he's going to have something like non-surgical valve implantation. These are the photos when I used to work with Dr. Kribbear, and 1996, 97 with my family. Then he came, this is my son Chinmay on the cycle, and with him at his residence. And he came to my residence in Delhi. In about 5 years back, he came here, and this was one of the ESC meeting. And this was the first Indian case, you might not know, the first Indian case of TAVI from India was done in France. That was November 2011. And at that time, it was not approved in India. So TAVI was not approved. It came in 2015 to 16. And the patient was closely known to me and referred by a cardiac surgeon of reputed in Delhi, that Dr. Vivek can take him to France with Alan Kribbear to doing it. So this was done in 40 minutes in a patient who was, the slides are not coming here. So the plan of presentation is scope of the problem of degenerative aortic stenosis. Degenerative aortic valve is the most common acquired valvular disease in adults. 26% of the population above the age of 65 has mild to moderate disease. I have to actually There is another slide. Just give me a second if I can open that, because that had the videos. Uh, uh, PPT कौन कौन सी दो हैं ये? नहीं देंगे. I think this one, yes. So I'm going with another set of presentation. So this was the wonderful stay in Rua. I told you, Dr. Kribe and the cycle, and November 2011 was the case of the first Indian patient, and a visionary man, pioneering team. The first case was done in 2002. Celebration of the 20th anniversary of TAVI and May 21, 2022 in Rua. I was there with Dr. P. Sirat also there. There are few memorable videos of Alan Crebier, myself, and this was the last video. I want to tell that this is the last video when he came to India in Kolkata CSI. I took a picture, a video with him while he was in the just checked out, and he was sitting in my room. Can you put the volume up?
In a single year like 2022,
So this is important that this was the last video recorded with him, and that was in France, sorry, in Delhi, in Kolkata.
under local anesthesia, with very short hospitalization.
It's nice to hear his original voice.
Discharged after the operation, just 2 days later. And so it's very successful. And so I was very happy to be invited in Calcutta, for the CSI meeting, where I presented the history of development.
This is December 2023, and we lost him in February 2024. I never knew that this is my last encounter with him, face to face.
With Professor Alan Crebier, who is the father of transcatheter aortic valve implantation, which is a non-surgical technique, and he did the first case in 2002, April. We are already celebrating 20th and then 21st and 22nd year. He's in France, he's in Kolkata during CSI. He's my mentor, my friend, my fatherly figure or brotherly figure, I don't know, but I think he has been in my past life somewhere. That's why I have personally so much of attachment and respect for him. Maybe we were living together in the past life. So may I request you to just speak 1 or 2 sentences regarding your innovation and yes.
Well, this is an innovation, consisting in replacing the aortic valve in aortic stenosis patients with degenerative aortic stenosis. And if the valve is not replaced at the onset of the symptoms, the mortality rate is extremely high. So many patients cannot be operated on for surgical valve replacement, and this is why I developed a non-surgical technique, for doing the same, replacing the aortic valve without surgery. And so I started in 2002, and now
Vimal, you must have met him multiple times.
3 million patients implanted.
He was supposed to get a Nobel Prize actually for his innovation of transcatheter aortic valve implantation, and his name was nominated by French Society of Cardiology last year only, but he was not selected. So coming on to the next video.
Just to give you an idea of the development of this technology, which allowed to replace the aortic valve under local anesthesia.
So this was the video which when I was working with him in 1997, the way he used to teach me.
Of French cath lab जो मैन्योग्राफी करता था
1996
के साथ में 4 सितंबर 2000
you can see he was also a good coronary operator.
Godfather like I'm working.
In fact, he was one of the fastest I ever seen. The time I used to scrub inside, he had already finished the left coronary angiogram. So this is the time when he came to my house, and it's again a very interesting video, very humorous, and you will be very happy to see his style. He was my residence in Delhi.
Mentor, guru, godfather. What else? My friend, I think.
Try to find something stronger.
Wow, this is yes, well, that's better. Professor Alan Crebier in my house at Sarita Vihar, New Delhi. It was my last
so many years wish that he can come to my house for some time. So I'm very happy that you have come, and it was very short, but the next time you have to come in a bigger way with a dinner. Not just
Not just a cup of tea. I leave the place very hungry, so this is not fair.
not fair.
Very humorous person.
You say something.
Yeah, it's in the cold here. I'm sorry, everything. Oh, I'm sorry. It's cold.
It's cold.
No, well, we drink, we have been drinking alcohol, so we are keeping it present.
At the moment, yeah.
Well, no, it's a great moment. We enjoyed the dinner and the atmosphere and the football and everything. And it's the first time that I come to your house.
Yes, that's why I'm so happy.
Well, not the last time. I
Of
can
course.
tell you.
He said no, not the last time, but he could not come after
Why
that.
did you come with us?
Yeah. So, like Chinmay, Chaitan, my wife, together with our.
I want to clarify something. He is your son.
Don't forget, if you're forgetting the name, don't forget that he's your son. Okay, so
Really, what time spent Rua. I still have very fond memories. I still have very fond memories of.
This is my colleague, cardiologist.
this is my colleague cardiologist. So this is recently when I was there, he was driving his Mercedes and I was sitting there. I had the pleasure of,
So
he was driving the car and I was sitting with him. It's one of the rare thing to have with such a legendary
and
figure.
he's driving at the moment Mercedes hybrid car, made in France,
Yes, no, made in Germany.
made in Germany. And this is Rouen. You can see all through. This is a church here, 23rd of May.
Chaitan is sitting behind,
2022,
enjoying
along
this
with
car
Chaitan.
ride.
We're sitting in the back.
Well, actually, we'll have to stop the car near the.
This was again another interesting small video during the 20th celebration. The way he used to have a affection for me. Just see his hand. This is my son Chaitan playing piano at his residence. Chinmay, sorry. The one who is standing working with you. Chinmay. And then few more videos. Welcome address. This I want to show here. Hello.
Dearest friends and colleagues from India and from other countries, this is Dr. Alain Cribier speaking from Rouen, France, sitting on my piano. And let me tell you, it's a great honor and a great pleasure to give you these few words of welcome address at the beginning of this conclave meeting. I must apologize, and I sincerely regret not being able to be physically present with you for various reasons. But I have seen the program, and I must congratulate Dr. Vivek Gupta for all the efforts and energy that were certainly necessary to build the program together, with a number of conferences and video cases. It is covering all aspects of modern cardiology. I am sure that you will enjoy it very much, and I do hope that you will have many opportunities to share your experience and interact with a number of faculties, most of them being my good friends. Also, at this special period of the year, I would like to wish you a wonderful and peaceful year 2019. My friends, have a great meeting, and I hope to see you soon.
Okay. This was another interview which I took in 2022 in France, in Rouen, in his hospital where I used to work.
I'm Professor Dr. Vivek Gupta, and it's my big privilege on 20. I'm Professor Dr. Vivek Gupta, and it's my big privilege on 23rd of May 2020. But
Still, I would say not
local anesthesia and femoral artery, so it was a much simpler procedure than opening the chest and doing heavy surgery. So I developed this procedure. It was 15 years of research. It was a very long time.
15 years of research.
Yeah.
15 years of research. This is very important.
Yeah.
His passion for the valve is there. He's not only a valve person. He has done a lot of angioplasties. In fact, what that means.
Yes, well, actually, I had some ideas, but I didn't have enough time to do that. But I developed a mitral commissurotome. It was another instrument, to treat another valve disease, which is very common in India, mitral stenosis, and I am very proud of having developed this device, which was working very well as well. So I did also a new coronary stent with Medtronic, and but many things, but nothing to the level of percutaneous aortic valve implantation, because this is really a revolution, and it has revolutionized the concept of treatment of valvular disease in the whole world. So this is something very great, and I am very, very satisfied of the result.
For the last thing which I want to tell you, that the French Society of Cardiology has already nominated him for the Nobel Award, and we hope and pray and take the blessings of God Almighty that soon he should be decorated with the Nobel Prize. And we all know that somebody who is nominated and who is deserving for the Nobel must be a very, very big man. So I always tell all my people and my family and my parents and my God blessing that I had the privilege to work with him when I was 30-year-old, 29, then I came to him and worked in this hospital. And of course, he was already a big man because he did the first aortic valve balloon dilatation in 1985, published in Lancet, and the whole world was looking at him. Whosoever the best cardiologists of the whole world, they came to Rouen to see how it performs that innovative technique, and he was already a celebrated person, but he became more celebrity because of transcatheter aortic valve implantation.
Yeah, thank you very much, Jack. Thank you.
I really appreciate your love, affection, and you have to come to cut the ribbon of our proposed Indo-European Medical College.
We have to be limited, you know.
Of course, but we have to keep trying.
It will happen. Sure. Okay.
Thank you so much.
Okay. Thank you. Thank you.
So coming to the topic, I will briefly, with 5 minutes, I'll tell you how much people are waiting for another talk. So scope of degenerative aortic valve stenosis, but balloon aortic valvoplasty, development of non-surgical aortic valve, and then case report, which we did the first time. Developing TAVI, a long road, littered with pitfalls, lesson learned from the experience. The reason why he said never give up, perseverance is the key word if you want to do some innovation. Since 1985 in Rouen, they did the first aortic valvoplasty, and then 2002, the transcatheter for 20 years gap. It was a long, difficult road for him to do innovation. So 1985, glory, then breakup, a bomb effect on the medical community. Everybody was saying that this aortic valvoplasty, how he could do. 40 years later, BAV is still alive, but it's required because before putting a valve inside, you need a balloon aortic valvoplasty. So this here too, in 1994, people said that most stupid project ever heard, just forget it. This was the Medtronic people and Edwards who were selling like hotcakes. They said, we will not support this idea. This is the most stupid project ever heard, just forget it. So then he wanted to make himself, and then they made a startup company in 1994. And they were looking for the sponsor, 94 to 98, looking for a sponsor. All biomed company contacted, complete failure, opinion of experts, cardiac surgeons, the most stupid project ever heard, just forget it. Then they made the PVT, named the company by the name of PVT with the help of Martin Leon, 1999. At that time, I had left back to India. 2 engineers, 2 cardiologists, Alan Kribier, Martin Leon, partnership, Ebron RD, an Israeli company made a prototype. The first PVT heart valve was developed in 2000. And the first in men was done in Rouen, in TAVI, which is this. So this is what I want to tell, that it was a difficult thing for do, and whenever you do an innovation, and I was told by Elaine, I did not know that 100 animal experimentation were done before doing the first case. So April 16, 2002, the dream comes true, famed TAVI, 57-year-old dying patient, cardiogenic shock, EF of 12%, multiple comorbidities, and second bomb blood TAVI as the last resort option was unplanned transseptal approach. Surgery was impossible to do, all the surgeons have said, and he was almost dying with a cardiogenic shock and post-bypass. Aortic valve area 0.6. The second bomb blast within the medical community is superfaction, enthusiasm, incredibility, and fury of cardiac surgeons. Surgeons said the fury of cardiac surgeons, him again. First you did the balloon aortic valvoplasty, and now you're doing the transcatheter aortic valve implantation. So this was the bicuspid valve actually. The pre-TAVI, post-TAVI, normal LV function. The first case was bicuspid aortic valve, which was done by him. And then of course, this was further improved, and from 2002 to 2005, there were 38 patients which were done, and they were all compassionate patients. That means very high-risk patients who were not surgically operable, and they were NYHA class 4, imminent death, and in most of the cases, transseptal approach was used, 75% success, and they found, you can see the few pictures of the people who celebrated, there was some trumpet blowing, and this was a great picture from it was actually from 2002 to 2005. And the first step at TAVI offshore, some breath difficulty with Vancouver, then Detroit, New York, then Rotterdam, Patrick Saraz, Antonio Colombo, Milano, and they have started doing this. And 2005, the 100 patient mark was passed. And 2004 onwards, Edward Life Sciences acquired PVT. The same company, is very interesting, the same company which had completely refused the idea of Edward, which was approached by him in 1994 or 96. The same company now acquires PVT. A big fish acquiring the small fish. PVT was a startup company, and now the Creeper Edward valve was then known as Edward Sapien valve. This was patent which was done. The Creeper Edward, initially it was Creeper Edward, and then it was Edward Sapien valve, and with the two approaches, of course, the transcatheter as well as antegrade and retrograde approach both became. 2005, launch of the current device, self-expanding core valve, started with the Eberhard Grube in Germany. They started self-expanding. Of course, the Dr. Krieger device was a balloon expandable valve. The launch of this, and no one could have predicted the prodigious expansion of TAVI over 20 years. The reason of success, continuous and rapid technological improvement, making TAVR easier, faster, safer. Major drop of severe complication, rigorous scientific evaluation following a challenge, a very unusual pathway in medicine, from higher risk to all comers. And then this is, you see, lot of valve developed the vascular approach, anatomy and valve sizing, technological and rapid technological improvement, making TAVR faster, easier, advanced TAVI system. 2005, 2009, 2012, since 2020, Sapien 3 was developed, and 2012, Evolute was developed from the other side. That was a self-expanding, and then Accurate Neo from the Boston Scientific, and then Merrill made the MyValve. So a lot of technological advancement, and the growth was too. The transfemoral approach has become the default strategy, most of the cases with the antegrade approach, not the retrograde. And transfemoral approach makes the procedure simpler, faster, and safer, and increase the number of potential candidates. Pioneered by our group, they said that this the reason for success is minimalist approach, that means without general anesthesia, and the patient minimal, that means like stenting, they start, and this is what we are doing now. But I want to tell you, at that time, 2010, it was difficult for other persons. Most of the American cardiologists they did with the general anesthesia, but they were doing with the minimal industry. Then partner 1, partner 2, partner 3 trials, they confirmed the efficacy over the surgical aortic valve replacement, and then of course the low risk and high risk. So partner 3 confirmed that low risk patient can also be treated with this TAVI. In the early days, nobody could have predicted the expansion of TAVI of 24 years. The hypothesis of TAVI, FDA approved TAVI in 2019. That was the most important day. Then FDA also approved this TAVI, and especially in the low risk. How can we predict the future? The future is bright. Some remaining issues are there. TAVI will increasingly concern a population of younger, lower risk patient. I was talking in the morning how the younger patient can be taken up, and the low risk patient, that means the patient who are otherwise safe to be operated, can they be taken this? Yes, today TAVI is being done in most of the low risk patient also. The prevention of minor complication, preserving selective coronary access, higher procedure of bicuspid aortic valve, being prepared to increase number of single vessel disease. So developing TAVI, a long journey from 1995, the first balloon aortic valvoplasty, then 2002, the first in case man, partner 1 in 2009, partner 2 in 2016, partner 3 in 2019, FDA approval at the same time. And of course, the 37 years since BAV, 22 years since first in man, that this is growing like anything. I want to tell you the first case which we did from India, a 0.7 centimeter square patient, valve area, peak gradient of 85, mean gradient 65, hypokinesia. This was a high risk because it was long-standing diabetes. previous bypass surgery, elderly age, graft patency status was okay, which was evaluated, and poor lung function that was deterrent against open heart surgery. Surgical consultation led to conclusion of high risk vertebral valve replacement. Pre-what this was done, the patient was treated with technical. We'll show you the angio clips, not having time, but I want to show the last clip, especially the pre-procedure disc. And you can see how the valve is going at that time. But of course, this is a common thing now in India, we are doing it, but it was the first case. That's why I want to tell you the first from India was done in our patient, but by Dr. Cribier in France. So this patient improved, and the patient was out of the cath lab within 40 minutes, exactly the procedure time from the puncture to puncture. The patient out was within 40 minutes. This is how the valve was going. It is not moving. And this is the valve which is going, and then finally it is deployed, and perfect deployment, and the patient was discharged the third day. Mean gradient improved. There's a minimal aortic leak which improved over a period of time, and then of course the patient was discharged on the 5th day with conscious sedation, first Indian patient. So it's a roadmap, and this is a tribute to Dr. Alan Cribier, this presentation, and you can see this was a Rouen which was full of this. It was the 10th year actually. May 2022 was 20th year. So this was the 10th year celebration, then we had 20-year celebration. In fact, which was a very interesting case, and I still miss him a lot. I feel that he's still with us. That's why I have not removed his name from the brochure, which still says that Dr. Cribier is a course advisor, and he is still advising, maybe with eternal blessings. He had a special affection for me, and I think I was one of the very few cardiologists. I would say I was the only cardiologist with whom he could come to the residence and shared his dinner time with me in time when it was not a conference. He came for the French embassy time. So this was a tribute. I think Dr. P.C. Rath is there online. Okay.
Yeah, it's still here. Thank you very much for that excellent presentation about the life of Alain. He was really, as you all know, the leader in the field of structural valvular intervention. So it's I visited him early, I think in the late 80s or early 90s to learn about valvuloplasty, and then he did the first, together with me, or we did together the first TAVR here in Germany, so back in 2005. So yeah, very impressive talk and nice views of the life of Alain. Thank you very much for that.
Thank you, Dr. Sievert. You are one of the important person and one of the eminent and renowned cardiologists from Germany, and doing a lot of research and conferences. So I would like you to stay back, and there is a talk by our friend from US. From US, he will be talking. Are you ready, Dr. Aravinda? Hello? Dr. Aravinda, are you ready? We have two international talks still pending. Dr. Alfredo Glassi from Italy and Dr. Aravinda from US. So,
yes, good morning. I am present here. Can you hear me?
Dr. Alfredo?
Yes.
Okay. I think you can, Dr. Aravinda has a slide still there, how to preserve. What is the topic of talk, Dr. Glasio? European consensus of the management of patients with CTO. Dr. Aravinda, are you here? Hello? I think he's not here, so you can, but is he contactable? Let me just have a look on his phone. He's on the way. I think you can start your talk, maybe, Dr. Alfredo. Can you share your slide?
Yes, of course I can share your slide, my slide.
So introduce yourself. He's from Italy, our new friend. He's now a new course director of this conference.
Can you see my slide then?
Yeah, I can see your slides now. So he will be talking a very interesting. Dr. Vimal Mehta is a European consensus on the patients of CA2s. We have Dr. Vimal Mehta, Professor of Cardiology from another big hospital, public hospital, GB Pant Hospital, and Dr. A.K. Kundu as a chairperson, and of course Dr. Sivat maybe is still there, and Dr. Abdul Rashid Khan from Pakistan, and they are on Zoom available. And so let's listen to your talk. Dr. Sivat, I think, must be listening from Germany. You must be knowing him. He is still there. He's there with a very nice, bright blue T-shirt. Young man. So please go stay with us, and I will have a talk from one of the very eminent cardiologists from Italy. And he's our, I would say he's still he's a now new friend for IECR, because he is now the course co-director of this conference, and we hope to continue under his leadership more such programs. So please go ahead with the topic of European Consensus on Management of Patient with CTO. I would like to tell you, you see, you are on Facebook Live for more than 10,000 people and YouTube Live, and it will be seen by many people even after the conference. So CTO is chronic total occlusion, because I want to tell you the physicians are also listening. That chronic total occlusion is you can describe yourself, and but this is just for introduction, that this is a chronic, means a long-standing blockage inside the coronary artery, and that becomes a challenge for the interventional cardiologist, because you cannot pierce it easily. Normally when you have 99 or 90% blockage, you can put the wire across easily, but when you have 100%, and that to chronic total, Dr. Vimal Mehta is also doing a lot of chronic total occlusions. So then it becomes it. So he is going to talk about the consensus from the European Society of Cardiology, or European consensus for management of patient with chronic total occlusion, which otherwise becomes a very challenging for the patient. Please go ahead, sir.
Thank you very much. For me, it's a great pleasure to be part of this big 21st Indo-European course on revascularization and Indo-European American conclave, and I'm really glad and honored to be to have assisted to your presentation on TAVI, and also to have to see on the screen of Sievert that I remember since the first time he came to Sicily. So for me, it's a great pleasure, and I really thank Dr. Vivek Gupta for this kind of invitation. And as he said, chronic total occlusion remains similar to TAVI, sort of tip of the iceberg of coronary revascularization for many, many years. Now, after 20 years from the beginning of the new emerging technology coming from Japan, nowadays revascularization of chronic total occlusion is being really sort of open to most of the cath labs, and percentage of success is really pretty high. So I will go in details in the describing what is basically the clinical indication to revascularization, which is been the topic of this recent European consensus published on the Euro intervention. And here you can see these are my disclosure. And so basically, this consensus came up as a statement from the IPCI, which is the European Association of Percutaneous Cardiovascular Interventions, the European Association of Cardiovascular Imaging, and the European S Working Group on Cardiovascular Surgery. So basically, not only interventional cardiologists, but also imagers and also surgery. And basically, what we have been shown is basically that nowadays patients with CTOs are coming both as symptomatic or sometimes also asymptomatic. And when they come symptomatic, not only angina pectoris is the first symptoms, but also dyspnea and heart failure comes sometimes as a first stable symptoms. And this comes sometimes when you as a stable symptoms, or sometimes also as an acute coronary syndrome in multivessel disease with discovered CTO. And this is usually sometimes the case also although very rare, as an cardiac arrest. Also, symptoms and asymptomatic patients can be also presenting under acute hypoxemia or acute bleeding with severe anemia, and CTO are discovered as a sudden type second myocardial infarction, which is not discovered. Also, an accidental finding by non-invasive tests has been found sometimes when we do often CT angiogram, and we found an opportunity. We can find the presence of a CTO, CTO coronary. So as you can see, in this case, most of the time, this comes asymptomatic disease. So in this wide spectrum of possibilities, you can find that basically not only the stable angina patients comes as a patient for CTO, but also other situations are. What are the situations on the coronary outcomes nowadays? And this is been recently published by Dr. Badalaf, one of my fellows from the University of Palermo. And basically that, as we said already, these patients are taking a lot of anti-angial drugs, but what is, and they are coming as symptomatic with both for angina and dyspnea, both, as you can see, 70%, 40% only dyspnea, but both symptoms, 50%, almost 50% of the cases. What is interesting that the CTO PCI technical success now is ranging almost 90%. And as you can see, antegrade and retrograde are both strategies that are used for revascularization, 70% generally speaking antegrade approach and 27-30% retrograde approach. It is interesting that the retrograde are carrying the most risk factor for MACE, and also that females are the patients who are having the most MACE of this, in this regard to this population. Also, MDO, which is a medium volume operator, as you can see, are going to have higher MACE in terms as comparing with higher volume operator. In other words, people who have more experience are, of course, are decreasing the likelihood of MACE, while those with medium volume operator, despite being dedicated to CTO, still may not really having the best of diminishing of likelihood of MACE as compared to higher volume operator. Also interesting in these CTO patients that radial approach as for coronary arteries are bringing the lower likelihood of MACE. And this is something which is now more and more frequent to be used, radial approach, even in CTO interventions. Then what else regarding the symptoms? First of all, we know that CTOs are very beneficial for symptoms of angina and dyspnea, for exercise tolerance, reducing self-images and increasing leisure self-images, reducing drug burden, and also reducing the need for less activity in terms of sexual activity. But of course, this comes mainly from a study which has been the more cited study, randomized multicenter trial European community that has shown that basically when we compare medical treatment to CTO revascularization, we have a significant increase and reduction of freedom of angina patients and reduction of angina frequency and physical limitation for those patients who are going into the revascularization program, which at the end is reducing, as you can see, when we compare optimized medical therapy to PCI, the class, CCA class during follow-up. And this is something that is for sure something that is been certified in all studies, but this is also the first randomized study to show that. But of course, health outcomes and quality of life is not only one of the part of the issue, but also reduction of outcomes is another important issue. And for this heart outcomes reduction, death, myocardial infarction, stroke, and repeated revascularization are those endpoints that we are trying to reduce when we look at heart outcomes. And we can see basically that in this meta-analysis, summarizing all the outcomes studies, overall CV cardiovascular death, when we compare success to CTO-PCI to fail CTO-PCI, for sure there is a favors which favors success to CTO-PCI, but it's not the issue. The issue is when we compare CTO-PCI to no CTO-PCI. And when we look to the right part of the slide, the comparison between CTO-PCI to medical therapy, then, and we try to reduce overall cardiovascular death, we understand that when we look at the observational studies, these studies are favoring CTO-PCI. But when we look to the randomized studies, unfortunately, this comparison does not favor CTO-PCI. And this is something that is quite strange and quite unusual. However, I think that most of the issue comes from the problem that in this comparison between randomized studies and not randomized studies, we usually use different population. In fact, as we say, as it's been shown in this editorial by Megali, recently published on JACC in the version 2022, patients in randomized studies do have fewer comorbidities, they have extensive crossover, they have less complex CTO features. While when we look at the world registry, which includes the real CTO patient, we understand and we compare really much more complicated CTO revascularization procedure. Also, we have higher procedural success because the operators are more dedicated operators and thus the results of the studies are more successful. And then we have, of course, a different population, which is totally probably the evidence for not comparing not properly comparing randomized studies representative of real-world patients, and probably this should be interpreted with this limitation. However, when we look to this randomized study, which is under the same of the previous study that I showed you for quality of life, and heart endpoints, and we compare, as we can see, primary safety endpoint, cardiac death, and non-fatal myocardial infarction, we realize that these are similar. However, when we look at the situation of the MACE, and then in this situation, MACE including ischemia-driven hospitalization, ischemia-driven target hospitalization, then we are clearly showing that there is a reduction of MACE for those patients who are undergoing PCI as compared to those who are going to optimize medical therapy. And this means that these patients are coming back more frequently to our ward for symptoms of ischemia, and they need more and more angiography, which are for sure another heart endpoint considered among cardiac death, non-fatal myocardial infarction, and non-cardiac death. So going back now to the appropriateness and the percutaneous we published a paper almost 8 years ago, which showed to us and clarified basically which were the patients who were needed to undergo CTO revascularization. And in this regards, a part of the symptoms, which was general symptoms, not specified, we described that akinesia, and this kinesia should have viability, and normal wall motion in the case of ischemia burden evaluation should have been evaluated in terms of revascularization if appropriate. However, after 8 years, as we can see in this next paper, which is exactly our consensus, we are firstly showing that not only angina is the symptoms, but also dyspnea and health status. And in addition, that we should undergoing revascularization. Of course, if there are symptoms in normal wall motion or hypokinesia, but in the case of akinesia or dyskinesia, not only looking to viability, but also looking to ischemia. And especially in the case of no symptoms, probably no need of revascularization in case of normal defunction, and only revascularization in case of absence of symptoms, in case there is significant ischemia and viability in those patients in which basically there are special class of patients which can improve significant prognosis. Like, for example, we can understand that patients with a younger age and proximal CTO may be reevaluated in terms of revascularization, although no symptoms, and only in case of ischemia viability is present. So this is something that is a little bit more conservative than in the past. Finally, we also underscore the importance that for looking to ischemia and viability that so now are going together, not only viability, but also ischemia and viability together. We also underscore the importance not of only of echo techniques and nuclear techniques, but mainly of CMR and CTCA, which is now largely distributed over all countries, and they can also increase the significance of looking for viability and ischemia. Looking to the last slide, we should also remember that CTO revascularization in the case of isolated CTO, it should be in case of non-LAD CTO should be taken into consideration, but in case of LAD CTO should be taken into consideration in terms of CTO complexity and local CTO PCI expertise, porcelain aorta, aortic arch atherosclerosis in the terms of an RTIM evaluation. This also is interesting that we also need to revascularize and consider the vascularization indicated not only when CTO validity alone is considered, but also in the context of multivessel disease or in case of previous cabbage, once again, taking into consideration the heart team evaluation. And looking, especially in CTO in the context of multivessel disease or CTO in previous cabbage, to the surgical risk, the availability of arterial venous conduits, and the concomitant relevant valvular disease, as been shown before by Viver Gupta regarding the issue of the increase of patients with TAVI that also have CTO coronary arteries. And looking also to the issue of bleeding risk and hybrid revascularization, which can be also taken into account in a sort of RT evaluation. Thank you for your kind attention.
Excellent exposition of whether to intervene in CTO intervention or not, where symptomatic definitely needs to be intervened and has shown the benefit, where if it is asymptomatic, there is no need to intervene. Thank you.
Thanks,
Thank you.
Thank you so much, Dr. Galassi from Italy. And you had done a fantastic job giving a talk on the chronic total occlusion, which is a very important aspect of interventional cardiology, where you have to open the arteries with the, and you have to talk, you have given a perfect, so we have, you stay back here. If Dr. Aravanda from US is corrected, then we can have his talk quickly. And Dr. Mansoor Ahmed is also there along with us. So can we have Dr. Aravanda is here? Okay, I think he's not there. We can start the session, or you 5 minutes can. Oh, Dr. Aravanda is here. Okay, Dr. Aravanda, because he's waiting there for last almost an hour. Adi Yadav, would you like to speak for 5 minutes? Exactly 5 minutes there only. Your talk is important, no? Disupramide. Honorable Minister, Honorable Minister जी, मैं आपसे बस 10 मिनट और लूँगा. Let us, because they are waiting for last time. उसके बाद हम आपको honor करते हुए जो program है, ठीक है? If Dr. Aravanda is not there, you can give a quick talk about the disopramide, and he's a very important antiarrhythmic, but don't take more than 5 minutes, please. Dr. Adi Yadav is a very important cardiologist from Delhi. He is working in Patra Hospital, and I welcome again Dr. Vanda Bagga, who is a Director of Health Services, sitting on the right of Honorable Minister, to come back all the way. Okay, so quickly 5 minutes.
Okay. So disopyramide in ventricular arrhythmias, particularly this drug is effective in ventricular tachycardia, as well as the most important use at the present moment is in hypertrophic obstructive cardiomyopathy with obstruction. With obstruction, this is the drug of one of the drug of choice, along with the mavacamten, beta blocker, verapamil. So in ventricular arrhythmias and hypertrophic cardiomyopathy, this disopyramide acts on the sodium channel
rapid acting sodium channel. It's a moderate effect and it slows the conduction and increases the action potential duration. So depresses sodium permeability during phase 0, increase threshold for excitation and decrease upstroke velocity, prolong the PR interval, decreases rate of diastolic depolarization, that is phase 4, upstroke velocity 0, phase 0, and disparity in refractoriness between the infarcted and the normal cells, established homogeneity between the normal and infarcted area, lengthening the refractory period, increase the action potential duration, and no effect on alpha or beta adrenergic receptor, shortens the sinus node recovery time and lengthens the effective refractory period of the atrium. It has got anticholinergic effect, 0.06% that of the atropine, and usual dose, if the weight is below 50 kilogram, dose is 400 milligram per day. Loading dose, if require VT, if you want to treat VT, you have to give loading dose of 300 milligram. Action starts within 3 minutes to 3 hours. Those hemodynamically stable VT, that you can treat with this. And severe ventricular tachycardia dose is 400 milligram and maximum dose is 1600 milligram per day. Or if the patient is already on quinidine or procanamide, you can switch over to the disoparamide directly. Another, the dose in renal failure is also reduced. So if above 40 ml per minute of the GFR, then 400 to 600 milligram per day, 30 to 40 ml, 100 milligram every 8 hours, maximum 300 milligram, and 15 to 29 ml per minute, 100 milligram every 12 hours, that is the 200 milligram per day. And if below 15 ml per minute, then it should be reduced to 100 milligram every 24 hours. And the only, you have to take regular ECG to know whether there is QTC is increased or not. Otherwise, and some dry mouth, these side effects are because of anticholinergic effect is there. Hypertrophic cardiomyopathy is the main indication nowadays for disoparamide, and particularly those who are obstructive type. And as you know, hypertrophic cardiomyopathy is defined by the myocardial left ventricular wall thickness more than 13 to 15 millimeter or 15 millimeter, and this thickness without any hypertension or aortic stenosis, no cause for that obstructive, there is no cause for hypertrophy, that is called the hypertrophic cardiomyopathy. Although nowadays there is a idiopathic hypertrophic LV is there, that also exists, but hypertrophic cardiomyopathy is the most common cause and it's a genetic cause. 50%, majority of them are autosomal dominant. They present with outflow tract obstruction, diastolic dysfunction, and heart failure with preserved ejection fraction. And the treatment at the present moment, it is associated with systolic anterior motion of the mitral septal contact. And if the gradient is more than 30 millimeter of mercury resting or more than 50 millimeter of mercury on provocation, which occurs in more than 2/3 of the patients, they need beta blocker first. Choice is beta blocker, and then if does not respond with the beta blocker, then you give disoparamide, and nowadays mavacamten. Since mavacamten is not available at the present moment in India, so we used to give disoparamide. And disoparamide is found to be quite effective in reducing the gradient in LVOT. Apart from that, as I told you, the SCM is genetic disease, mostly autosomal dominant, and is associated with disarray of the myocardium, along with the myocardial hypertrophy and increased interstitial fibrosis. Small vessels of the coronary arteries become narrowed down, which lead to ischemia, and this disarray and increased wall thickness, scar in the myocardium leads to diastolic dysfunction as well as the ventricular tachycardia. And these two all are decreased by this disoparamide patients. The mavacamten, if will be available, I think the problem is mainly the cost, and till then, if till not available, disoparamide is very important drug. And as you know, histopathology of the SCM is associated with myofibrillar disarray, which leads to anisotropy and leads to VT. This is the typical of case of HCM. And I think that's all we need. Apart from this, there are other use like short QT syndrome. where if quinidine is not available, now quinidine is fortunately started available in India, then disopyramide is the drug of choice. So these are the use of disopyramide. Thank you.
Thank you, RD. Always a good friend, and he can speak in sleep also. Do you give lecture during sleep also? So, so we have to interrupt the scientific program for a while. I'm honored to be here with two big singers, Ankita Pathak ji. She came a little earlier, and I think she must have enjoyed the talk. And then our other friend who's sitting here. So what I will, because Honorable Minister has to leave, Dr. Mansoor Ahmad, we have actually, I will just invite our minister on the dais, and because he has to leave in 20 minutes, he says. So we will have a small talk, and before that, I will introduce about the conference to him so that he knows a little more about the conference and how we're doing it. And then the talk from Dr. Dhiman Kahali, who is the President of Cardiological Society of India. Dr. Adi, please stay back. You have to be honored by Minister. And to may I invite Honorable Minister to be coming onto the stage. Can you just escort him with the, can you bring the bouquet and the shawl? My father was supposed to join, but he will be coming a little late. Dr. Kundu, you can stay here. And please, sir. So let me introduce, bring the shawl and bouquet and for the minister and the trophy. May I request Dr. Vanda Baggaji to please honor our, you can also come on the stage. She is a medical doctor and the Director Health Services in the Government of Delhi. My wife can join here, Dr. Rakhi Gupta. आ गए क्या? अब बाहर आ गए क्या? हेलो, आ गए आप? बाहर आ गए, ले आओ, बड़े दिन से हैं. हेलो, आ गए आप लोग बाहर? हाँ हाँ बताइए. तो दिस इज फॉर डॉक्टर मतलब का किन के लिए? So I just want to request Honorable Minister to honor Director Health Services Vandana Bagaji. Okay, may the Honorable Minister be seated. हाँ हाँ, कहाँ पे अभी आप लोग? आइए आइए, मैं भेज रहा हूँ किसी को बाहर. आइए. So Bade Dinesh ji is also just reaching within 5 minutes. May all be seated. Introduce the topic and so I would start with the valedictory function. We'll have something to show as per the
Five-year-old male. Can you show this to the, can you just share this slide? Sir, आपका moment. So let me start this valedictory function as an integral part of the conference. Honorable Minister, we have been doing this conference, which is an education program for the cardiologists of all over the world. And I would like to just have a small attention of the Minister. This is the conference which we're doing for the last almost 12 years. Just want to have your attention. Can we have this on the slide? I just wanted to introduce our conference. It's an Indo-European. I used to work in France actually, in 1996 to 1998. And after that, I joined Apollo Hospital, and since then I'm working there. And the basic purpose of all such education program is to enhance the capacity of learning, so that finally it reaches to the healthcare for the people who should understand and teach and treat the patient to have reduced this. So we started this conference in 2008 with Dr. Alan Cribier. He's sitting here, right here. He came to me. He's one of the Nobel laureate and one of the very eminent and renowned cardiologists. I just had a talk about him about half an hour back. And in 2008, we started this program. The first meeting was held in Vigyan Bhavan in Delhi. It was a 3 days course with 15 live transmission sites, and all aspects of interventional cardiology, including TAVI symposium, were discussed. International faculty were huge from France, and this was first Vigyan Bhavan at that time. Then Chief Minister Mrs. Sheila Dikshit was the chief guest of this program, and this is the first ICR, and then we had live lectures. Further, we planned all the.
Further, but Dinesh ji is there, so somebody has to receive him. Further courses were held in universities of London, Paris, Amsterdam, Rome, and Zurich, and later in India. This is the 21st course of ICR, which is being held in Delhi now, and next course will be held in academic collaboration with the Institute of Andaman Nicobar Island in coming June. So this was a small introduction of this. I wanted to show you some videos. Before this, basically the learning videos which we do is, I want to share some videos of the life-saving angioplasties. And
Namaskar, Professor Dr. Vegupta
आवाज
from
थोड़ी कम कर
Apollo
दो जरा.
Hospital along with Lalit.
Sound complete.
8 जुलाई राधिका पेशेंट. अब ये हमने एंजियोग्राफी करी, हम आपको दो बातें बताना चाहते हैं. हमने इनके स्टेंट लगाया था 2017 में. लोग कहते हैं स्टेंट चलते नहीं है, स्टेंट टेम्पररी होते हैं, स्टेंट बंद हो जाते हैं. 4 साल तो ये गवाह दिख रहा है, इतिहास गवाह है. तो 4 साल तो स्टेंट देखिए हमने
So this was actually, I wanted to show that the stents are almost lifelong. A few videos I will shortly before we have your talk.
नमस्कार प्रोफेसर डॉक्टर वेगुप्ता.
And then we will show you some life-saving angioplasties, which we do in our setup. And life-saving, this is very interesting. And this patient I wanted to always show. So this is a patient which we did about 5 years back. It's very interesting because this was almost dead because he required lot of cardiopulmonary resuscitation during the time when he came to our Apollo hospital. At that time, I would say he was almost dead because if there was another delay of 10 minutes, we would have lost him. So this patient was actually auto rickshaw driver, and I was telling that the ECG showed severe heart attack and he was having a cardiac arrest. So our team in hospital, they revived him on ventilator and on basic life support, and he was shifted to cath lab for some other doctor who said that it is too high risk a case, so we should not do this case. We should not do this patient. Nothing should be done. Somehow this Dr. Azhar was here, sitting here. He said, "Ki doctor, let me talk to Dr. Vegupta. He might take such a challenging case because it's always a risk. If the patient dies on the table, then there's always a blame comes that if there was no procedure done, perhaps he would have survived." But I thought that I saw his two children. They were standing with him because he was just 35-year-old, and उस समय मैंने देखा कि अगर इसको हम एंजियोप्लास्टिक, वैसे भी he is not going to survive, अगर मैं इसकी एंजियोप्लास्टिक कर देता हूँ तो शायद ये बच जाए. तो मैंने ये बात कहते हुए उसकी पत्नी से बात की. मैंने कहा कि देखिए मैं कोशिश कर सकता हूँ. दिस इज डॉक्टर अजहर, आवर CMO टीम. ही कॉल्ड मी, एक्चुअली आई वाज सिटिंग इन OPD. तो मैंने कहा कि मैं ट्राई कर सकता हूँ. तो इसकी हमने एंजियोप्लास्टिक की. हमने जो नसों में ब्लॉक खोला है तो ये हमने खून का थक्का निकाला इसमें से. व्हाई आई वांट टू शो बिकॉज दिस वीडियो फेसबुक लाइव जा रहा है सर. ये लॉट ऑफ पीपल विल लर्न फ्रॉम दिस. और खून का थक्का निकालने के बाद हमने इसका स्टेंट लगा दिया और हमने इसको शिफ्ट कर दिया बाहर. ये दूसरे दिन का वीडियो है. और फिर हमने इसको ये पेशेंट वाज in the CCU and the patient is still living. This is the man with whom we worked in 2181 bed number ICU in Apollo Hospital. So I always give that means I always tell all my junior colleagues, Dr. Vimal Mehta, he was cardiologist in GV Pant Hospital, that you should always give a chance to the patient. Out of 10 patients, 9 will survive, 1 may not. But does not mean that you should not do it. So this patient is still living. He came to me about, well, he does not come to me regularly. He comes once a year. Just healthy baat hai. He has not stopped smoking, but he's doing very well. So I'm very happy to tell you about this patient. This was a part of my teamwork, which I want to tell you. And before I put, there are a lot of messages from Dr. Thavle Saab ka video hai, which I would like to share with you, because he has not gone back to Bombay, so he will not be able to. लेकिन आपके सामने बताना चाह रहा था. इन्होंने अच्छा बोला है. और ये आवाज बढ़ाई थोड़ा सा.
प्लास्टिक हो या बाईपास हो, उन्होंने किए है. और इंडो यूरोपियन हर्ट कॉन्फ्रेंस जो है, ये कॉन्फ्रेंस होने जा रही है. इसमें लंदन है, पेरिस है, आम्स्टर्डम है, ऐसे कई देशों के जो रिप्रेजेंटेटिव है वो इसमें आ रहे हैं. और मुझे बहुत बड़ी खुशी होती थी अगर मैं ये कॉन्फ्रेंस अटेंड करता था तो. लेकिन ये डेट थोड़ी इस कॉन्फ्रेंस के लिए हार्दिक हार्दिक को बधाई देता हूँ, शुभेच्छा देता हूँ. और कॉन्फ्रेंस में जो भी सभी अटेंडेंट जो आ रहे हैं उनका मैं स्वागत करता हूँ एज ए सोशल. और मैं सभी को हार्दिक हार्दिक बधाई देता हूँ.
And there is another videos, but I don't want to take much time. Let me have just बड़े दिनेश जी आ जाएं, शायद बाहर ही हैं. Then we'll start the talk from the speech. I would say very precious speech of Honorable Minister. There are one thing. This was Kailash Vijayavargi talking about conference.
नमस्कार, मुझे बहुत प्रसन्नता है कि मैं मित्र डॉक्टर विवेक गुप्ता जो कि इंद्रप्रस्थ अपोलो में कार्डियोलॉजी के डॉक्टर हैं, 2008 से इंडो यूरोपियन कंट्रीज़ के साथ प्रमुख डॉक्टरों के साथ मिलकर कार्डियोलॉजी के लिए कॉन्फ्रेंस करते हैं. 2008 से लगातार चल रही है. मुझे भी निमंत्रण मिला था, किंतु मैं व्यस्तता के कारण उपस्थित नहीं हो पा रहा हूँ. पर इस कॉन्फ्रेंस के माध्यम से नए डॉक्टर सीखें और आने वाले समय में क्या क्या चुनौतियाँ उसको समझकर अपनी सर्वश्रेष्ठ योग्यता को सिद्ध करें. मेरी ओर से बहुत बहुत बधाई और शुभकामनाएं.
ये एक वीडियो मैं दिखाना चाहता हूं सर आपको. दिस इज आवर प्रोफेसर एलन क्रिबियर. ही हैज डन कई इनोवेशन किए हैं. इनका नोबेल प्राइज में नाम था. और इन्होंने ये लास्ट इंटरव्यू है इनका, क्योंकि अभी थोड़े दिन पहले वी लॉस्ट हिम. ये इनके साथ ही मैंने सीखा है फ्रांस में. और ये एक बहुत बड़ी, ये दिसंबर 2023 का वीडियो है. और उसके बाद फरवरी में वी लॉस्ट हिम. बट ये इन्होंने एक नए वाल्व टेक्नोलॉजी को इजाद दिया है, जिस पे हम अभी भाषण दिया मैंने, कि बिना ऑपरेशन, बिना छाती खोले हुए वी कैन डू एओर्टिक, बिना छाती खोले हुए वाल्व बदल दे. वाल्व स्टेंट तो लगता ही है, वाल्व बदलना. तो दिस वाज हिज स्मॉल इंटरव्यू व्हिच आई वांटेड टू seek his blessings, and I have worked with him in France for a long time, and then everything I have learned from him. तो ये बहुत बड़ा धक्का हमारे लिए. लेकिन अभी भी पूरा जगत इनको, पूरे दुनिया जो कार्डियोलॉजी जगत है वो इनको अभी नमन करता है.
pleasure of working with him in 1996 to 98.
अच्छा, मैं तो बात
was not only a very good cardiologist, all my angiography.
So I think let me introduce Honorable Minister now. Where is my phone? मेरा phone कहाँ गया? And then I can take his speech. एक और वीडियो मैं आपको दिखाना चाह रहा था, ये जो अभी
Okay, I'm Dr. Vivek Gupta. 20th of December. I just showed you the film where we had a large clot and we took out with the angioplasty thrombosuction. और उससे हमने निकाल दिया और स्टेंट लगा दिया.
Okay, this was before that. Five-year-old male with a thrombus and clot stop in the ostium of the LED. ये कॉर्नरी आर्टरी है जहाँ पे हम लोग एंजियोग्राफी करते हैं. और ये जो सफेद सफेद दिख रहा है, ये क्लॉट है एक्चुअली, खून का क्लॉट. So we have done a quick wiring, double wire, and then with the thrombosuction device. Show again the thrombosuction device. When could receive that? अच्छा, बेटा डॉक्टर बंदा बग्गा, डायरेक्टर हेल्थ सर्विसेज. मैं हृदय से, दिल से आभार व्यक्त करता हूँ. बड़े दिनेश जी ने समय निकाला, और ख़ास करके ऐसे समय में जब बड़े बिजी थे. और मैं दिल से आभार व्यक्त करता हूँ डॉक्टर मिस्टर हर्ष मल्होत्रा जी, हमारे जो परम आदरणीय मेंबर ऑफ पार्लियामेंट हैं ईस्ट दिल्ली से, और इसमें मिनिस्टर हैं फॉर द स्टेट फॉर द कॉरपोरेट अफेयर्स. मोदी जी की गवर्नमेंट में ही इज़ वन ऑफ द वेरी इंपॉर्टेंट मिनिस्टर. इन सब ने समय निकाला। हमारा ये अब थोड़ी देर पहले मैंने बताया था कि ये कॉन्फ्रेंस जो हम लोग करते हैं, अब आदरणीय बड़े दिनेश जी के लिए बता रहा हूँ, ये हम लोग इंडो यूरोपियन कॉन्फ्रेंस है। यूरोप के डॉक्टर्स, अमेरिका के डॉक्टर्स हम लोग मिलके एक टीचिंग प्रोग्राम करते हैं, जिसमें कि हम लोग सिखाते हैं लोगों को, डॉक्टरों को, कि ये क्या क्या नई विधियां हैं एंजियोप्लास्टी की। ट्रेनिंग से लोग सीखते हैं और फाइनली हेल्थ केयर के जो लोग होते हैं, फाइनली फ़ायदा हम लोग कोशिश करते हैं कि प्रयास करते हैं कि जो मरीज़ हैं, रोगी हैं, उससे मृत्यु दर कम हो। तो बेसिक पर्पस सारा ये कॉन्फ्रेंसेस का यही होता है। शाम को एक छोटा सा वैलिडिक्टी फंक्शन करके आप लोग जैसे लोगों का आशीर्वाद प्राप्त करते हैं, ये हमारा उद्देश्य है। ये 21वीं कॉन्फ्रेंस चल रही है जो अभी समाप्त हुई है, और सुबह से करीब 22 टॉक लेक्चर हुए हैं, जिसमें से 5 अमेरिका से और करीब 7 यूरोप से और बाकी इंडिया से। ये सारे लेक्चर्स सुबह से हो चुके हैं। इसमें 2 ऑपरेशन दिखाए गए, जो इसमें हार्ट के ऑपरेशंस हैं, ये रिकॉर्डेड ऑपरेशन थे। और इससे हमारे करीब यहाँ पे 300 डॉक्टर, सुबह से काफ़ी लोग थे यहाँ पे और शाम को लोग चले गए। इतवार का दिन है, नया साल आने वाला है, तो सुबह से काफ़ी लोग, हम लोग 9 बजे से यहाँ पे प्रोग्राम चल रहा है ये। और शाम को आपके आशीर्वाद वचन के लिए हमने आप लोगों को निमंत्रण दिया, तो आप लोग आ गए, इसके लिए मैं आपके हृदय से आभारी हूँ। और मैं चाहता हूं कि आप अब थोड़े से 5 मिनट में 2-4 लोगों को मुझे ऑनर करना है, और ऑनर करने के बाद आपके प्रवचन को सुनते, उसके बाद हम लोग एक संगीत का प्रोग्राम करेंगे। तो आप बैठे और कुछ खाने का प्रबंध अगर पॉसिबल हो तो हो जाइएगा। आपको ट्रेन पकड़नी, मुझे पता है, इनकी 8 बजे क्या टाइम हो गया इनको, हाँ 7 बजा है, इनको 7:30 बजे यहाँ से निकलना है। तो अभी एक्चुअली क्या करता हूँ कि आपको ये थोड़ा सा ऑनरेबल मिनिस्टर साहब का आप नहीं, आपको तो बोलना ही है, आपके सुनने के लिए तो हम लोग सुबह से आते रहे हैं। तो ऑनरेबल मिनिस्टर के बारे में थोड़ा बता दूं यहाँ पे। ही इज़ ए मेंबर ऑफ पार्लियामेंट फ्रॉम ईस्ट दिल्ली, and he very much he is so much I would say Modi ji is so much liking him. That's why he has become the minister out of 7 member of parliament in all the seats है। और मैं चाहूँगा कि आप अपने वचन दें। आप बोलेंगे? ठीक चाहिए सर।
ओ, मंच पर आसीन हमारी श्रद्धेय बहन, हमारे यश, हमारे सांसद जी महाराज, और आपका नाम याद नहीं आ रहा, आप मिले हैं, और यहाँ पर सभी डॉक्टर के नाते आए हुए सभी बहनों और बंधुओं, जैसा एक शब्द मैंने सुना है केवल कि हम प्रशिक्षण देते हैं। किस चीज़ का प्रशिक्षण देते हैं ये सब आप जानते हैं। मेरा केवल 2 वाक्य डॉक्टरों के दृष्टि से। एक तो वास्तव में सभी को मेरा आग्रह है कि जो चरक शपथ है, उनकी शपथ को आप प्राप्त करिए, नहीं तो मैं भेज दूंगा व्हाट्सएप पे और उसको पहुंचाइए सबको, उसको जरूर पढ़िए। एक डॉक्टर के नाते से किस रूप में, किस भावना से, किस मानसिकता से, किस योग्यता के आधार पर अपने काम को पूरा करना, सब कुछ उसमें है। दूसरी बात, डॉक्टर का चिकित्सा बाद में समझ में आती है, लेकिन उसका जो व्यवहार है, स्वभाव है, स्वभाव नहीं कहेंगे, व्यवहार, वो पहले समझ में आता है मरीज को और तीमारदार को। तो वो जो एक व्यवहार अपेक्षित रहता है, जिसके कारण से हमारे पुरानी कहावत बनी, आज भी ग्रामीण अंचल में उसको वाक्य को बोला जाता है, डॉक्टर भगवान का छोटा भाई है, इस रूप में उसको मानते हैं। इसलिए भगवान का छोटा भाई डॉक्टर इस जो भूमिका में अपना स्थान है, उसका निर्वहन हम अच्छे ढंग से करते रहें अपने इस जीवन में, यही अपेक्षा है और मैं प्रभु से प्रार्थना करता हूं कि आप सब अपने कार्य में कुशलता के साथ यश प्राप्त करें। भगवान आप सब पर कृपा बनाए रखें। ओम सभी को प्रणाम।
मैं रिक्वेस्ट करूंगा आदरणीय हर्ष मल्होत्रा जी ऑनर करें बड़े दिनेश जी को। अंकिता पाठक जी आप आ जाएं, 2 मिनट आपका ऑनर करना है। और त्यागी जी आप भी। डॉक्टर भंडारी जस्ट फॉर द मोमेंट, यस। आशीष गुप्ता जी हमारे ब्रदर है, वो स्टेज पे आए, जरा ऑनर करें। ऑनर चिन्मय आप आके आशीष और चिन्मय दो मोमेंटो और ले आए जरा। मोमेंटो आशीष और नहीं वो है my real brother Ashish Gupta, he is a president in a Barco company, और ये मेरे छोटे बेटे हैं, बड़े बेटे हैं, सॉरी। डॉक्टर भंडारी भंडारी इज द प्रेसिडेंट ऑफ दिल्ली मेडिकल एसोसिएशन, इनका भी स्वागत करेंगे डॉक्टर हर्ष मल्होत्रा जी। इसी कड़ी में हमारे प्रोग्राम तो काफ़ी बड़ा है, काफ़ी लंबा चलेगा, चूंकि दोनों जो हमारे भाई के उनका है, इसलिए मैं चाहूँगा कि अपने आशीष वचन से हम सब का मार्ग, क्या कहते हैं उसको, मार्गदर्शन करें।
भारत माता की। काफ़ी देर से आप लोग बैठे हैं, तो थोड़ा भारत माता की जय जोर से बोलेंगे तो ठीक हो जाएगा, नींद वींद खुल जाएगी अगर किसी को नींद आ रही होगी तो। भारत माता की। आशीष वचन तो आदरणीय दिनेश जी ने दिए हैं, बहुत
आधे लोग चाय के लिए चले गए।
महत्वपूर्ण 2 बातें बताई डॉक्टर फैटर्निटी के लिए। मंच पर उपस्थित आदरणीय दिनेश जी, डॉक्टर कुंडू, डॉक्टर वंदना, डॉक्टर विवेक, जिन्होंने मुझे यहाँ आमंत्रित किया आप सबके बीच में कार्डियोलॉजी की इस कॉन्फ्रेंस में आप सबके बीच में मिलने का, बात करने का। ये बात बिल्कुल ठीक है कि आज पूरे विश्व स्तर पर भारत समेत नई एडवांसमेंट्स और नई टेक्नोलॉजीज भी आ रही हैं और नए रिसर्च पेपर्स भी आ रहे हैं। इस तरह की जो कॉन्फ्रेंसेस रहती हैं वो बेसिकली बेस्ट प्रैक्टिसेस इन द वर्ल्ड उनको आपस में शेयर करना और उसके ऊपर डिस्कशन करने के बाद उसको पेशेंट्स को, जनता को ज़्यादा से ज़्यादा फ़ायदा हो। एक चीज़ इंडिया में किसी रिसर्च पेपर में कोई बात आती है, वो अमेरिका के लोगों को भी फ़ायदा होना चाहिए। जैसा मुझे बताया कि अमेरिका से भी 7 लेक्चर थे आज, और
2 वेट कर रहे हैं,
2 अभी वेट भी कर रहे हैं, और एक और कंट्री से आपने बताया 5 लेक्चर, इटली, जर्मनी। तो ये कोविड का एक फ़ायदा भी हुआ कि हम वर्चुअल कॉन्फ्रेंसेस के माध्यम से भी पूरे विश्व में किसी भी कॉन्फ्रेंस में बहुत से लोग जुड़ पाते हैं। मैं जब आया हूँ, मैंने जो कुछ टॉक्स सुनी, हालांकि टेक्निकली बहुत ज़्यादा समझ में नहीं आया। एक डॉक्टर यादव ने अभी किसी मेडिसिन के बारे में बताया, कुछ कुछ समझ में आया, लेकिन दिस इज़ अ वेरी गुड एंड फैंटास्टिक फोरम सो दैट वी कैन शेयर बेस्ट प्रैक्टिसेस ऑफ द वर्ल्ड, और जो हमारे अपने एक्सपीरियंस और अनुभव हैं, वो जो अभी कुछ एक वीडियो मैंने भी देखा एक डॉक्टर साहब का, तो उसके माध्यम से हम पेशेंट्स को ज़्यादा से ज़्यादा फ़ायदा दे सकते हैं। और आपका फील्ड तो बिल्कुल लाइफ सेविंग फील्ड है। इसमें एक बहुत इम्पॉर्टेंट बात मुझे लगती है कि जो देश के प्रधानमंत्री आदरणीय मोदी जी ने भी मेडिकल फील्ड को और पर्टिकुलरली पुअर पेशेंट्स के लिए अफोर्डेबल बनाया है। आप लोग भी भगवान का दूसरा रूप हैं, लाइफ सेवर्स हैं आप लोग। जो भगवान की दी हुई जिंदगी है उसको आप सेव करते हैं, उनको बचाते हैं, पर उसमें हमारा एक निवेदन है कि इसमें इसे ज़्यादा से ज़्यादा अफोर्डेबल बना लेना चाहिए, जिससे कि कई बार बहुत से पेशेंट्स ऐसे होते हैं कि जिनकी पैसे के अभाव के कारण वो बच नहीं पाते हैं या उनका इलाज ठीक से नहीं हो पाता है। ये मुझे ज़रूर आप लोगों से कहना है। और अंत में ये मुझे बहुत अच्छा लगा कि आज आपने मुख्य अतिथि के रूप में भगवान कृष्ण को यहाँ बिठाया है। आदरणीय दिनेश जी, इस कार्यक्रम के मुख्य अतिथि भगवान श्री कृष्ण हैं, तो ये इनका आइडिया मुझे बहुत अच्छा लगा। और मैं ऐसा मानता हूँ कि कर्मण्य व अधिकारस्ते भगवान कृष्ण ने उपदेश दिया था, उसको उनका अनुसरण करते हुए हम समाज जीवन में समाज की सच्ची सेवा कर पाएंगे। आपने मुझे यहाँ बुलाया, बहुत बहुत धन्यवाद। भारत माता की जय।
सर मैं आपसे एक 3 मिनट के लिए रिक्वेस्ट करूंगा। डॉक्टर कैथलीन बिगा, शी इज द प्रेसिडेंट ऑफ अमेरिकन कॉलेज ऑफ कार्डियोलॉजी, शी इज जस्ट ऑनलाइन, शी वाज सपोज टू स्पीक लिटिल लेटर। मैं रिक्वेस्ट किया है कि अभी बोलें, तो वेल जस्ट टेक हर स्पीच। अमेरिका से उनके सुबह 8 बजा है इस समय, और 7:30 ही बजा होगा इस समय, तो मैं चाहूँगा 2 मिनट उनका अभिवादन सुन लें। और डॉक्टर जैक लोविन, वो न्यूयॉर्क से हैं, ये शिकागो से हैं, वेरी इंपॉर्टेंट, वेरी एमिनेंट कार्डियोलॉजिस्ट हैं अपने समय की। डॉक्टर कैथलीन, आई जस्ट गुड मॉर्निंग टू यू, कैन यू हियर मी? Can you unmute her? Dr. Kathleen, she is the president of American Society of Cardiology. And I have to inform you, Dr. Kathleen, that we are having our guest of honors, Honorable Minister, Mr. Harsh Malhotra, who is the minister in the Honorable Prime Minister's cabinet. And very important, from the another organization, Mr. Bade Dinesh ji. So I would like you to just speak for 5 minutes. Introduce yourself. Can you hear me? Dr. Kathleen Bega.
Can you hear me?
Yeah, we hear you, yes. So I'm saying that our valedictory function is on, and this is the right time you have joined in. It's early morning, 7:30 a.m. at your time, and I'm very happy that you could join. And I was just telling that one minister, Mr. Harsh Malhotra, who is a member of parliament and a minister in the Modi's Honorable Prime Minister's cabinet, is here, and our very important respected Mr. Bade Dinesh ji is also here listening to you, and we are all blessed that they are here and they're listening to your talk. Just 5 minutes, talk about the structuring of the chest filling clinic. Just say hello to them, introduce yourself also.
Thank you, Professor Gupta. And can you see my slides okay?
Yeah, perfect.
Okay, very good. And I see Dr. Lewin's on. So good morning, Dr. Lewin, to you. Good afternoon to all my Indian colleagues. It's great to see you. So I'm going to cover in 5 minutes or less how to do a chest pain clinic in your hospitals, because in India you have many of the same issues that we have in the United States. I was able to find one recent study that was done in North India that talked about the number of patients that actually come in through the emergency rooms with both chest pain and non-cardiac chest pain. And of course, that's one of our large issues, is how we're able to determine the actual etiology of our patients. So what we have done in the United States and many, many of our hospitals is designed, developed, and implemented what we call chest pain clinics. And that's what we're going to talk about a little bit this morning very quickly. In order to do this, this is sort of what we use for all of our subspecialty clinics. We have them for cardio-oncology, cardiometabolic, cardio-OB, lots of different subspecialties as the field of cardiology continues to evolve and the complexity of our patients continues to also evolve. So we don't have time to go through each of these, but just in case you wonder how we get to the end point, this is really how we do it. And we do it by utilizing disease management because our patients really have to be cared for in a personalized way. We don't have time to talk about the social determinants of health, but much like in India, really understanding where our patients come from, making sure they have access to the right care at the right time, and making very sure that we use our guidelines in order to drive the appropriate therapy, and then always being able to review exactly what we have done to ensure that we're doing the very best that we can for our patients. So we start by looking at systems of care, not individual silos of care. So we do that by looking at our services, such as a chest pain clinic, our cardiac cath lab. We look at our different programs, and then we look at our entire system of care, because just like in India, care does not just happen in the hospital. It happens throughout the community and making sure our patients get there. Those of you that have heard me speak when I've been to India know that I bring Sam with me. Sam is our patient who comes into our clinic many different ways. He comes in through primary care, he comes in through your clinic, other specialty clinics. Many times they come through the emergency room. We're going to talk about interjecting the chest pain cleaner before we get to procedural care in order to meet the demands of our patients. So very, very important. So what is the solution? The solution is to utilize the pathway so that we can differentiate, diagnose our patients, making sure if they have non-cardiac chest pain that they have further workup so they don't continue to come to the emergency room. Of course, if they've got coronary artery disease, making sure that we're managing that, obviously through prevention if possible. And if they have obstructive coronary disease, as you saw in the cath lab films that we just saw a couple minutes ago, we obviously want to make sure they get to our cath lab in a timely way. So how do we do that? We do it very simply through an organizational, clinical, and then operational. We have to design it with our physicians leading this charge, making sure that it's structured appropriately, making sure the care coordination is there for our patients, and then always looking at our different processes. So by assessing where we're going, I call that our true north, assessing how we get our patients out of the emergency and make sure they don't come back, make sure that we develop collaborative pathways with different stakeholders, which could be our emergency room physicians, our primary care physicians, so it's very multidisciplinary. Then we have to implement, and as always, as you hear us talking from the college, and I did forget to introduce myself, sorry, Dr. Gupta, but I am the current president of the American College of Cardiology. So using the college and all the tools that we have, making sure that we do performance management or quality indicators. Risk stratification is critical. So in order to risk stratify, which of course we don't have time to go through, we want to really make sure that we've got non-cardiac, STEMI, non-STEMI. So we have to be very sure how we do that. And we do those through the two major risk scores that we have on the screen here for you. Obviously the TIMI risk score, which many of you are very familiar with, as well as the heart risk score, which sort of helps us identify across the continuum exactly how our patients should be handled in a timely manner. And then we implement the chest pain center. So we decompress the emergency, remove them into a separate section of the emergency room. High number of patients coming in with shortness of breath or chest pain, making sure we have easy access to imaging. That's the most critical thing, as well as our labs, making sure that we have patients access so they can get in. We do not want them waiting in our waiting rooms. We want to make sure that they're there quickly. We do not want to admit them if it's not necessary. So that's the critical component. Many of the chest pain clinics start with about 6 bays, depending on how large your hospital is. We do allow us to have about a 24-hour length of stay. We like to discharge the patients quicker. And of course, with coronary CTA, that has become much easier. Obviously, our troponins and BNPs are important for both our heart failure and our MI diagnosis. And as I mentioned, access to CV imaging is very, very important. So how do you design that chest pain clinic? Obviously, these are the types of patients that we triage immediately over to the chest pain area, which is immediately adjacent to our emergency rooms. Triage them quickly, draw their labs, do their ECG. We have our advanced nurses. In India, you use your specially trained nurses. They are our initial triage individuals because the cardiologists are obviously
Training,
very
yes.
busy. They're then seen by the cardiologist in order to determine the level of imaging. And of course, with coronary CTA, triple rule-outs, it's become an extraordinarily valuable tool for us. So just in summary, looking at our risk stratification, as we look at our emergency rooms and exactly how we can treat our patients by utilizing that risk score. It's a methodology that we use in order to ensure that our patients are seen in a very timely manner by our appropriate individuals. I'll just leave you with the differential diagnosis components that, of course, as physicians, you know very, very well, and then the references for you. And with that, I thank you so very much for allowing me to join you on a Chicago Sunday morning, and good evening to all of you there. Thank you so very much.
Thank you, Dr. Kathleen Riga. It's very nice. And I would just like another 2 minutes, Dr. Jack Lewin. He's our friend and he's also former CEO of the American College of Cardiology. He will just speak 3 minutes with our honorable ministers and Adani Bade Dinesh ji. He is a former CEO. Jack Lewin, very important tall figure of America with a cardiologist, being CEO of CRF, Cardiological Research Foundation. And he's a former president of ACC or CEO, American College of Cardiology. Let me tell you, American College of Cardiology has a membership of about 10,000 people or more than that, Kathleen.
50, over 50,000. I want to say that President Biga, it's wonderful to see you, and I'm so delighted that you're in this position now after all the years we've worked together. So really a delight to see you. And it's a delight to see many of you here. I've been to many of these of the IECR meetings over the years, and I'm so glad, Dr. Gupta, that you decided to honor Professor Alain Cribier because of his amazing accomplishments, but also because he was at this meeting year after year, and we would see each other if nowhere else. We would see each other as through your auspices here at IECR. We really want to see, I've been working with the US federal government on a project to try to create a better system of care in the US. We have great technology. We have, a great deal of research and science going on in this country. And we have, a lot of innovation happening here. But at the same time, our healthcare costs are becoming unaffordable for us. And so we have some major challenges to resolve. And that's particularly true in the cardiology space. The American College of Cardiology, in partnership with the American Heart Association, has really done amazing things. The NCDR, National Cardiovascular Data Registries, collects virtually all of the inpatient cardiovascular data in the US and then applies science to that, including artificial intelligence, to try to see how we're doing and to give feedback to hospitals and physicians to help them understand how we can do better together. I would put a challenge out today to all of you at this wonderful meeting and to Dr. Gupta as well, for us to work in an even greater way in collaboration. We'd like to learn what you're learning and share our information back and forth. International collaboration in cardiology will be very important for the future ahead of us. I am working with the federal government now to use states as the models for how we can improve our system. And we look forward to working with you in the future and with all the wonderful faculty that you've assembled here in that effort to make it a global cause together. So thank you, Dr. Gupta, and for all of your honorees and for the very, very esteemed attendees today for bringing this meeting together and for inviting so many important people around the world to participate in it. Let's enhance that participation and work together to improve cardiovascular care for the citizens of the planet, of every country. Thank you so much for this opportunity to be with you today.
To summarize, Dr. Jack and Dr. Lewin and Dr. Kathleen, that we have to have more partnership so that we can reduce, we can learn, and we can reduce the cardiac mortality, which is often coming. And now I would like to tell you that in India, we have young patients having major heart attacks, young, especially 30-year-old, 35, 40. And we have to find a way out to reduce the vulnerable plaque so that the young people should not die. So I would like to have further collaboration. We already have collaboration to ICR, and maybe our government of India can also enhance this collaboration. Our chief guest is leaving. You stay on. I have to just relieve him because he has a train to catch, and another minister has a meeting. They're all busy people. Let me just have. So, Dr. Jack, I can call you Jack because we have so many interactions. Dr. Kathleen is also here. We can have just, I wanted to find out how ACC and IECR can collaborate because the president of ACC is here. And we have been doing this conference for last so many years. You know this is 21st IECR conference, started with Dr. Alan Crevier in 2008. So we can have some joint statement which we can release for the government of India. And we have a director health services sitting here right away, right, director health services of government of Delhi. So just before we wind up with you, there is another talk. Can you stay back for 10 minutes? We have a talk from Dr. Arvinda Najan, who is American. Is he available on phone? Because that's the last talk available. Dr. Arvinda is here. If he's here, we should have his talk because he's waiting for last 2 hours, almost 2 hours. Dr. Arvinda, is he? But he's already joined. Ask him to open his Zoom. Dr. Kathleen, can you stay back for 10 minutes? Okay. Because he will be happy to have you presence because he's a senior cardiologist from, I'm just talking to him on phone. He says, I can present now. Let me call him. He's talking on bifurcation, something like that. But that will be the final talk before we will have musical program after this. Dr. Arvinda, can you come quickly now? Because Dr. Jack Lewin and Dr. Catherine Biga from ACC are already online. Hello? How long will it take to 5 minutes? Okay. So he says 5 minutes because he's already on the round because he was waiting. So can we just have a summarized view of Jack? You know better India, and of course, Dr. Kathleen was also here. Summarized view of how we can collaborate.
I think the most important area for us is to build and further extend our clinical research collaboration between India and the United States and to include other countries. That's an area where I think we can learn in ways that will include all people. The clinical research, unfortunately, has involved mostly white people in In developed countries, it's excluded women mostly, and it really has not included sufficiently other ethnicities. And there are differences among us, even though we're all human beings here on this planet together. We do have genetic and other physiologic differences that need to be understood better so that we can personalize medicine for everyone. And I think that there's a great opportunity to expand our research collaboration between the USA and India, and would look forward to seeing that happen in a much more robust manner.
Yeah, and I completely agree with that, Dr. Lowen. I think the other way that we have been able to work together and collaborate is through educational processes, such as obviously extremely exhibited by this Congress. Through our 43 international chapters, India has been extremely active in those chapters, doing a lot of research, but also preventative cardiology. We all know what our risk factors are. Our risk factors are not getting better, are just getting our patients to know their numbers, their blood pressure, their lipids. Those are just very apparently easy elements, but yet neither of our countries have been able to do that. So I think along with all of our colleagues, and as Dr. Lewin mentioned, research is so critical for all of us. We know that our Asian population, our Southeast Asian population, our Indian population present differently, and the pathophysiological changes during the disease process is critical. As I mentioned very quickly, understanding our social determinants of health, along with equitable access, are the two elements that the college feels are most important for collaboration. And so I just would continue that incredible collaboration that we have with our Indian chapter, with your governors. We've done a phenomenal job. India got our chapter grant, looking at air pollution and making sure that the children, because again, education can't start when we're 60. Education needs to start when we're 10 and 12. As we call it, being able to meet your grandparents. So we want to make sure the children of the world are able to meet their grandparents. And the only way we're going to do that is by controlling our risk factors through preventative cardiology. So I thank the Indian Society as well as the chapter for all that you do to help us. And of course, you know that I look forward to seeing all of you in my hometown in Chicago for ACC scientific session at the end of March. So thanks, Dr. Gupta. That was an excellent.
Yes, Dr. Aravinda is, I think, online. Dr. Aravinda, just introduce yourself. Can you ask him to open this video? Yes, please introduce yourself. We are actually at the end of the show, or rather conference, because voluntary function is already over, and we had a good talk. It was very nice that we had a talk or some valuable information by Dr. Jack Lewin while the guest of honor was sitting here. Our chief guest is Bhagwan Krishna. So Lord Krishna is our chief guest. Just tell you, I would like you to keep the talk not very, I think you talk general cardiology rather than bifurcation lesion, because it's not many interventional cardiologists in the room. So Dr. Aravinda, I would take this talk maybe in our port player conference, but just talk a general cardiology, how India and US collaborate and how your center can be a collaborative partner. Dr. Aravinda, without sharing the slides. Sorry for that small modification.
You need to give me 1 second. And Dr. Glenn, it's great to see you. Basically, I haven't seen you for a while. How you been doing, sir?
No, I was requesting you to talk a little general about how India and US can collaborate. We'll keep your talk this way when more interventional cardiologists will be here during our Port Blair conference in the coming first week of March.
All right. What I wanted to talk is...
you see, Dr. Jack Lewin from ACC and Dr. Kathleen from ACC are there online. So we want to just have a few words from you regarding how India and US collaborate to reduce the mortality, because Dr. Biga just spoke about the chest pain clinics, and Dr. Jack Lewin, who is the former president of ACC, spoke about Indian collaboration with ICR collaboration with ACC or Indian Government of India collaboration. We don't want, sorry for that, because at that time we had more interventional cardiologists. At this time,
no worry, Dr. Vivek, and thank you for providing this opportunity. Good evening, Dr. Levin and Dr. Biga. Thank you for being there at India. It makes us feel happy that top cardiology people from American College of President to previous ACC CEO is there. So I'm very happy. Basically, I think both of them know India has a very high incidence of heart disease, and this is something of my passion, despite me being here for 30 plus years in the United States, now working at Cleveland Clinic. I feel that I have not adequately contributed to my own home country to make it at par with US with what we do in terms of eradicating or at least stabilizing the coronary artery disease. The few big factors that I want to bring to point is coronary artery disease among Indians is on a very high incidence. It's at par with rising cancer. Basically, that's because the disease occurs about 10 years before coronary artery disease occurs in the Western world. This has been well published from Dr. Enos 30 years ago to recent studies such as Masala and Sneha study that was published very recently in AHA. Second thing is our lipid profile is really a high atherogenic protocol. What I mean is LP small a is very high. The ages of 40 to 50 are very vulnerable for heart disease, and we have a high incidence of both myocardial infarction and stroke, especially MI, and there's a lot of delay in diagnosis, a lot of delay in presentation, and when the patient presents, it's multivessel coronary disease. There's a very high premature onset of pre-diabetes and diabetes mellitus, which affects almost 25 to 30% of the population. So all these factors leads to high incidence of heart disease. A few other things that have made it worse is modernization in India has introduced a lot of fast food culture, less of walking, more of stress, and food availability has made the obesity to go up. So in short, the pre-diabetes, diabetes, rising waist circumference and raising weight of the patient, in return with less of activity has made coronary disease more predisposed. What I would love to request from both the ACC President Big and Jack Levin is if we can start to have a little bit more representation of ACC at the Indian meetings, and also have ACC representation how to identify heart disease in an early fashion, how to treat it in a better way, and also involve more in clinical trials, because most of the clinical trials, the guidelines are meant for Western world. This really does not suit the Indian population. We need to have something that relates to the Indian population. What I mean by that is India's population is 1.2 billion. It's not small.
1.4.
People across the world are Indians. But the clinical trials, if you look at it, the best enrollment has been 0.02%. That's very dismal from Indian subcontinent. So really, the guidelines does not meet the real. For example, we talk about BMI being less than 25 for United States, but the BMI less than 25 does not pertain to India, because the half the myocardial infarction happens in patients between BMI of 23 to 25 in Indian subcontinent. When I talk about Indian subcontinent, I'm talking about the Bangladesh, Pakistan, and Sri Lanka, all these countries.
We have people from Pakistan already logged in. Pakistan is also there. Yeah.
Indian BMI should be less than 23 for men, and women should be less than 22. Second thing is the waist circumference. There's a big role of waist circumference less than 32 for men in India and 30 for women. United States, we go with waist circumference of 34. So really there are differences. And we blindly tell everybody's LDL should be less than 55 for coronary disease in the United States. But we do not know in the United States, in India, maybe the LDL should be lower than this. So we need something like maybe a white paper that can come out in ACC about how best to address these deficiencies. We have several physicians from Shamir Mehta to Yunus, who has done tremendous work regarding disparity in coronary artery disease among Indian subcontinent. Maybe we can have a forum with them at the upcoming ACC to address these and see what inroads can we make, how can we change these things.
Thank you very much. I think it was a great insight about how Indians and American collaborate and how to reduce the heart attacks, especially in context with the BMI, which is a problem for not only for India, but also for America. Obesity is a big problem. So I think we conclude here with this with 30 seconds comment from Dr. Jack and Dr. Kathleen. And then we conclude here and finish off this meeting today. We have a singing team here. We do a cultural small. If you want, you can stay logged in to have some good Bollywood songs after this meeting. Uh, huh? Kathleen and Dr. Aravinda, Mr. Ashish Gupta will talk about a very quick 1 minute about AI and healthcare. So okay, so we'll have it later in the Port Blair meeting. AI is a very big, not challenge, but it's a very big, I would say, baby to have help us in healthcare. Okay, thank you very much. Any comment? Last comment from Kathleen or Jack?
I'll just do a quick last comment, let Dr. Lowen close us off. I think what we heard today was that we're all in agreement with how we can better collaborate through research and education and obviously preventative cardiology. You just mentioned AI, another critical element and a critical area that will be important to all of us in the delivery of cardiovascular care. Just remember to keep our patients at the center of everything that we do and make sure we personalize our care for our patients, no matter what part of the globe we live on. It's been an honor to be with you today. Thank you. Jack?
And I echo President Biga's comments. I think the AI is going to be important. We need to set some boundaries around AI. We need to do definitions. We need to make sure the data that we're using is the right data. And we're in a good position to do that and to collaborate on that as well. That's a very important area, an opportunity to expand our ability to improve diagnosis and treatment, but only if we do it in the most correct and scientific way and work together on it. So thanks for the honor of being here today. It's really been a pleasure. And Vivek, congratulations on so many years of bringing people together through IECR.
Thank you, Jack. It is your appreciation and the appreciation of the patients, especially, that we keep moving despite too much of work otherwise. And I really thank everybody who came in here and gave lectures and talks since morning. We had more than 15 talks, two case live inbox, especially Germany and US, and of course the two more talks in the from Italy, and so it was very delightful, I think, to have this meeting. And we are doing a Port Blair conference in Port Blair on March 1st and 2. And I would like if one of you can travel, or otherwise we'll have virtual planning to. Thank you, Dr. Aravinda, for staying back for a long time. You have to take the hospital rounds. Today is Sunday, but of course the rounds, yeah. Your Sunday morning, your Sunday evening here. Thank you very much, and thanks to everybody who's present here. And we'll have a small singing program. After a while, 15-20 minutes later, you can still log in to listen to the Bollywood songs if it is. I think they are very good to hear, because the music is a best healer, and the music has no language. So if the music has no language and is a best healer, try to log in if possible. Thank you very much.
Happy New Year.
Happy New Year. That's very important. 2025. Our friend from Pakistan, Abdul Rashid Khan, wanted to show himself, but he's not here, I think.
Yep.
Thank you so much. Happy New Year to everybody. Especially, you will have a new president in 16. You have a new president on 16 January, is it?
We already have.
No, but he's not yet officiating, no?
It is just this.
But otherwise, I'm a big fan of Donald Trump. Tell him. Okay, thank you so much. Bye-bye. अब यहाँ पे थोड़ा सा संगीत का प्रोग्राम शुरू करना है. काफ़ी लोग जा चुके हैं, कुछ लोग ऊपर हैं, चाय पी रहे हैं. तो यहाँ पे सेटअप लगाना है, के लिए जल्दी से आ जाएं लोग. जो लगाना है, we could have started the setup. ये आज कहाँ गए ये लोग? आप बैठिए यहाँ पे. हाँ वहीं बैठिए. हाँ that's better. अभी सेटअप लगेगा यहाँ पे. Who is in charge? कहाँ पे हैं? विशाल? नहीं, यहाँ पे लोग आ चुके हैं. मैं भी चाय पी लूँ थोड़ा सा. डॉक्टर आपका मिस्टर बनवारी जी बैठिए, आगे बैठिए. आई थिंक 15 मिनट लगेगा. कहाँ पे हैं डॉक्टर कुंडू? आप जाइएगा मत अभी, स्टे बैक. ये कहाँ पे हैं ये लोग? जो साउंड वाले कहाँ पे हैं? इधर बाहर हैं क्या? जुनैद पता करो कहाँ ये लोग, इनका सामान रखा हुआ है साउंड वालों का.